Good afternoon, good morning, buenas tardes, buenos días. Before I start, I want to let people know how to access the live Spanish interpretation. Antes de comenzar, quiero que la gente sepa cómo acceder a la interpretación en español en vivo. Se puede acceder a la interpretación en español en vivo haciendo clic en el botón Interpretation en la parte inferior de la pantalla de Zoom, icono del mundo. Una vez en el canal español, por favor, silencie el audio original. All right, thank you everyone for joining us today for the Administration for Community Living, ACL Traumatic Brain Injury Partners Day. My name is Terry Camacho Gonzalez, and I am the project director for the Technical Assistance Resource Center, the TBI Technical Assistance Resource Center, or TBI TARC, which is funded by the Administration for Community Living. This is the 2024 ACL Traumatic Brain Injury Partners Day, which is in observance of Brain Injury Awareness Month in March. We're a little early, but tomorrow is March. During today's event, we'll have sessions on brain injury and the criminal legal system, aging with brain injury, and bridging intellectual and developmental disabilities in brain injury and the mental health system, with the mental health system. This webinar is hosted by the Traumatic Brain Injury Technical Assistance and Resource Center. In today's session, you will also hear from my TBI TARC colleagues, Judy Detmer and Maria Crawley. This webinar is free and open to the public. And next, I'd like to go over some logistics. Next slide, please. So participants in the webinar will be in listen-only mode during the webinar. Please use the chat feature in Zoom to pose questions and communicate with the host. We will be looking at those questions, and during specific times, we'll open it up to questions. This webinar is live captioned in English and live interpreted in Spanish. Live captions can be accessed by clicking the CC button at the bottom of your Zoom screen. The live Spanish interpretation can be accessed by clicking the interpretation button at the bottom of your Zoom screen, the world icon. Once you are in the Spanish channel, please silence the original audio. Again, se puede acceder a la interpretación en español en vivo haciendo el clic en el botón Interpretación en la parte inferior de la pantalla de Zoom, el icono del mundo. Una vez en el canal, por favor, silencie el audio original. This live webinar includes polls and evaluation questions, so please be prepared to interact during polling times. Next slide, please. After the webinar, you can send follow-up questions and feedback to tbitarc@hsri.org. Please note that this email will not be monitored during the webinar, but we will get back to you as soon as possible. A recording, including a PDF version of the slides, will be available on the ACL website. You did receive a link to the ACL website, to the slides in your Zoom invitation email that came today. Next slide, please. Before we get started, we'd like to get a sense of who's attending this webinar. So you should all see a poll that popped up, and you can identify self-identify any roles that you fit into. Please select all that apply. It could be you identify as a person with a traumatic brain injury or other disability. You are a family member, a friend, a person with a TBI or other, self-advocate, a peer specialist, social worker, researcher, service provider organization, or you work for a government, either at the federal, state level. And we'll let it run until we get to about 80%. This really helps us to know who's here, and also for the presenters, what type of audience they're talking to. But we really love to have this information. And we're almost getting at 80%, so thank you to everyone that has already selected how you self-identify. Give it a few minutes. Okay. Shaska, do you think we should close it or just keep going? But anyway, just to get a sense, about 30 to 34% are people with direct care staff, social workers, case manager. We have 20% that identify self-advocate or a self-advocate. We have 12% people with a traumatic brain injury or disability, 26% are individuals that work for a service provider, and 41% are government employees. I know many of them are TBI State Partnership Program grantees in other states that are here. So thank you, everyone. And I did not share, but those are the results. And now, next slide, please. And now I'd like to introduce Sean Calloway, who's the project officer for, serves as project officer for the Administration for Community Living. Sean?
Hello, I'm here. Hello, everyone. Again, my name is Sean Calloway. I serve as a project officer along with Elizabeth Leaf on the TBI State Partnership Program. I also serve as the contracting officer representative for the TBI Technical Assistance Resource Center. I am so honored and humbled to introduce our next presenter. She was appointed as Principal Deputy Administrator for the Administration on Community Living back in January 2021. She currently holds the duties of ACL Administrator and Assistant Secretary of Aging. Also in her role, she advises our Secretary of Health and Human Services on issues related to disabilities and individuals who are aged in this country. Not only that, she's an advocate at heart. I know, and just reading her history and her bio, just working on policies that will enhance people with disabilities in the aging population in areas such as housing, employment, education, you name it, she's done it. So I am humbly and honored to announce our presenter, Miss Allison Barkoff. Allison, are you there?
I'm here, Sean. Thank you so much for that introduction, and thank you to everyone who's here today. Happy TBI Partners Today, and this day is really all about celebrating our shared partnership and recommitting ourselves to our common mission. I know that there is a lot on the agenda today, but I really appreciate the opportunity to take a few minutes to tell you that supporting people with brain injuries continues to be a priority focus for ACL. We truly appreciate your amazing efforts to advocate for people living with brain injuries. The public and everyone in government needs to hear from you. You are the experts, especially those of you with lived experience and your families and people who provide support for you. We need to make sure that we live in a society that understands the complexities associated with brain injury, that knows about the supports that must be in place, and that we create a society that respects and includes everyone with a brain injury. Today is the 7th year that we've marked this day, and I like the addition of the word partners to the title because that's exactly what we are, partners. This event allows ACL and all of our grantees and stakeholders a chance to gather and share our experiences and learn from each other. The mission of ACL is a mission I know we all share, supporting opportunities for community living for all. As we say in this community, all means all. And we are all together part of a larger movement, a movement that believes that people with disabilities and families and advocates from across the country can collectively make our nation better. That with proper supports, everyone can fully participate in their communities, can work, can live independently, and can enjoy their leisure time. But as a longtime advocate, I know nothing happens without us working together, and that we need to collectively work on systems change when it comes to brain injury. We know that we need to change the way we view the interface of brain injury and mental health, and how our criminal justice system treats people with brain injuries, and how we support people aging with brain injuries. Today, you'll hear from experts on how brain injury can impact a person's life, and how too many people with a brain injury still are not able to access the support they need. We do have work to do, work that can lead to systems change at the national and state levels, work that can lead to more people vindicating their right. It is a civil right for people to be part of their communities and for us to work together to make that right a reality for all. Sometimes when you're in the middle of things, it can be hard to see the progress we're making. But I do want to say we have made a lot of progress. And while we're not close to the finish line, we do have barriers that we're going to continue to work on. Employment, healthcare settings, legal system. And again, we need to make sure that everyone who has a brain injury can get the support that they need. Too often, people who have been historically underserved, particularly from people who are from communities of color or other underserved communities, have been overlooked. But together we can be a voice to make sure that we are really advocating for everyone. I just want to share in the vein of some of the progress that from inside and outside the federal government, we really can work together to make sure policymakers know how common traumatic brain injuries are and how they can result from so many different things: falls, motor vehicle crashes, sports injuries. And we'll keep a spotlight on the range of services and supports that people really need and explain how those needs can change over time. At ACL, we're really excited to be your partner. And this year, we have really tried to bring in the brain injury community into a number of cross-disability systems change efforts. We are really excited to have NASHIA as a partner, for example, in our new initiative that's focused on educating people with disabilities and their families on how to advocate for systems change related to home and community-based services in their own states. And we love that NASHIA has joined us as a partner in our initiative related to people with disabilities who also have mental health needs, an initiative called the Link Center. These are just two examples of many ways that we are trying to really lift up the needs of the brain injury community and make sure that we are really working together, arm in arm, lockstep across the disability community. So I just want to end by saying thank you to ACL's TBI Technical Assistance and Resource Center. You are working so hard to help the 31 state partnership programs promote access to integrated, coordinated services and supports for people with TBI, as well as their families and caregivers. So truly, thank you. Thank you to each of the TBI state partnership programs who work with local, state, and national organizations on a wide range of issues. And thank each of you who are here today advocating on behalf of people living with brain injury, and a special shout out to all of the self-advocates in attendance. Your collective voice makes a difference, and it is just really important that we work together. And I pledge that ACL will be right beside you, working together on issues that matter to you. So thank you again for inviting me to join and mark today's TBI Partner Day. Sean, the floor is yours.
Thank you, Allison. Wonderful. Thank you so much for that wonderful introduction. Also, before I introduce our next presenter, I want to mention Miss Elizabeth Lee, of course, works with me alongside of me with the TBI state partnership programs as well. So next up, we have presenting from the National Association of State Head Injury Administrators. She serves as Director of Strategic Partnership and Policies, Ms. Zita Ricker.
Hi, everyone. Thank you so much for joining us today for our first session on building a justice system that is inclusive and responsive to brain injury. As Sean said, my name is Zita Ricker, and I am the Director of Strategic Partnerships and Policy for the National Association of State Head Injury Administrators. And I am pleased to be moderating today's session, and I'm really grateful to ACL for recognizing this important topic focus area. As you all know, up to 82% of incarcerated populations have a past history of brain injury compared to 8% in the general public, which has led the CDC to recognize brain injury in prisons and jails as an important public health problem. And due to this alarming prevalence, in 2022, Congress passed and the president signed the TBI and PTSD Law Enforcement Training Act, which was developed and passed in partnership with NASHA. And as a result of this legislation, the Department of Justice Bureau of Justice Assistance has tasked one of their technical assistance providers, the Council on State Governments Justice Center, to hold focus groups and put together a report on how to best support people at the intersection of brain injury and the criminal legal system. And so today we're going to hear a little bit more about this report. I'm not sure if Megan has joined us yet, so I will introduce Megan in the chance that she does join now. And if she isn't able to join us, then I think Judy Detmer from our team will be able to talk a little bit about the report and its efforts. So Megan Davidson is a program director for the Council of State Governments Justice Center. And I won't go through Megan's entire bio, but she has over 10 years of experience leading efforts on the intersection of behavioral health and criminal justice. And we are grateful for her leadership on putting together this Council of State Governments report and for partnering so much with NASHA to help provide some recommendations that the Department of Justice, we are sure are going to take up and move forward. In addition to Megan, we are also going to be hearing from Tracy Barney. As a result of the legislation that I mentioned, the Bureau of Justice Assistance for the first time also recognized that supporting people with brain injury could be supported for funding under the Justice and Mental Health Services Collaboration Grant Program. And as a result, Utah's Department of Health and Human Services applied for and was awarded funding for this program to do some really exciting work on the overlap between brain injury, intimate partner violence, and the criminal legal system. And so I'm excited to hear from Tracy, and she is the Brain Injury Program Administrator at the Utah Department of Health and Human Services, who manages this grant. Again, I won't share Tracy's entire bio. I think it's in the materials, but she has been working in the field of brain injury since 2002, and her experience in the field extends to being a parent of someone with a brain injury. And NASHA is really grateful to be partnering with Utah on this grant and to hear from Tracy on this. I just really want to emphasize how exciting it is that the Bureau of Justice Assistance is focusing on brain injury. And this year we saw that, again, the Justice and Mental Health Services Collaboration Grant Program and an additional grant program, the Law Enforcement Behavioral Health Response Program, is recognizing brain injury as an eligible population to serve under these initiatives. So I'm excited to hear from Tracy about this funding that she received. I don't think
we're gonna start with Tracy.
Okay, great. So we'll have Tracy go first to kick things off, and then if Megan is able to join us, we'll go to her. I'll turn it over to you, Tracy.
Hello, thank you, and welcome everyone. Like Zadia said, I'm Tracy. I am with the Utah Department of Health and Human Services, and I'm in our Violence and Injury Prevention Program. I'm the Injury Response Manager, but I also am the administrator of our brain injury funds and program here in Utah. Next slide. So I'm just going to talk a little bit really quickly about Utah a little bit. In August of 2022, our Lieutenant Governor Deidre Henderson, her cousin was killed in a murder-suicide from involving an ex-partner. And this kind of led was a type of a catalyst for us to Utah to invest more resources and other things in domestic violence, intimate partner violence in Utah. So the governor, this is just a little bit that allocates about $53.5 million to domestic violence prevention in Utah. And between July 2020 and June 2021, we've had 240 homicides and 1,247 strangulation cases that involve that are related to domestic violence. Because of this, we had a physician who wrote a paper. He's with Intermountain Health, and he wrote a white paper on domestic violence and brain injury, and really focused on perpetrators. Circulated it, and it really brought up a lot of interest and buy-in on this project. Next slide, please. So we became aware of this grant. NASHA and Zadia's work and all their work made us aware of this grant. So the Justice and Mental Health Collaboration Program, it's funded through the Department of Justice and the Justice and Mental Health Collaboration Program. And it is aimed to reduce improve outcomes for individuals with mental health disorders or co-occurring mental health and substance use disorders who have come in contact with the criminal justice system, who are either leaving or are still in the setting. And for the purpose of this, the definition of someone with a mental health disorder and the services that could be provided through this program includes individuals with TBI and traumatic stress disorder. And when we became aware of this, we realized this really does fit with the white paper that was written and the interest in Utah that would help us, kind of address this. So we applied and we were awarded in October of 2023. So we're super brand new to this, but we're moving along, and it's exciting to see the work that can be done and the excitement around us. Next slide. So this is kind of the phases how this works. Is the first year is a planning and implementation phase. And we get our technical assistance from the Council of State Governments Justice Division. And then we also work through this plan for the first year of how we're going to implement, and we kind of plan. And that plan gets submitted to DOJ. And then if it's approved, it moves on to our implementation phase. It's a 3-year grant. And so we have the next 2 to 3 years to work on that implementation. And Utah is really unique in a way. Well, what we have programs that can actually work in this system that are funded through our several different funds that we have. So next slide. So our goal for this grant is to develop and implement a brain injury screening support and refer protocol for justice-involved women and perpetrators of domestic violence to reduce recidivism. And how we plan to do that, I'll go through a little bit of that in the next couple of slides, but reduce recidivism for justice-involved women and domestic violence perpetrators by providing some neuro-resource facilitation and rehabilitation to those identified with brain injury. Next slide. So here's our objectives. So of course, the first year we develop our implementation plan, and in that plan, we establish a brain injury steering committee. And this is just a few of the people involved in the steering committee. We have NASHA. Part of this plan does require that you do you have an MOU in place for Department of Corrections or your, state, what oversees that. So we have the Department of Corrections, we have the Brain Injury Alliance of Utah, important partners that provide our resource facilitation services, the University of Utah, and Intermountain Health. They are vital in providing the neuro rehab part. Department of Health and Human Services, that would involve my program and our Office of Substance Use and Mental Health. Our Utah Commission on Criminal and Juvenile Justice, Division of Domestic and Sexual Violence. We have a representative from there. Next slide. Sorry, I forgot to mention, there are a couple, we have some evaluators and epidemiologists that also sit on that steering committee to help us make sure that we're gathering what we need in order to show that our outcomes. Another objective is to develop and implement the following: brain injury screening and assessment protocol, which we are going to use the online brain injury screening and support system, OBIS, from NASHA. Then we will provide a support and referral protocol for that. We'll do psychoeducation curriculum that we'll develop, or if there is some, we'll make sure that that is fits into this program, and a lasting brain injury training for justice staff and community-based treatment providers. And then develop peer support to the target population. Next slide. And like I mentioned before, we use our traumatic brain injury and spinal cord injury fund. That does provide the neuro rehabilitation services. We have 3 providers of that fund. Currently, Intermountain Health is our main provider for this project. They're the ones that, helped us kind of get this going. And then our brain injury fund does the neuro rehabilitation, the neuro resource facilitation, and will also so it funds those neuro resource facilitators, or provide any outreach, that kind of stuff. So that fund kind of funds that. And we will also want to maintain our partnership with the Department of Corrections. They've been very, very engaged in this, and just a great, they see the need for our population, the brain injury in corrections, and the importance of being able to provide them with the services that are available to them. Next slide. Okay, that is all I have. I'm happy to answer any questions. Yes, question time.
Thank you, Tracy. We can ask some questions of Tracy now, and then we can turn to, I think it will be Judy Detmer from our team to go over the other portion. So if there's any questions in the chat. I did see one question. Can you describe a little bit more about the setting of those who are intimate partner violence survivors? How are you connecting with those folks?
Sure. So we're in the process of identifying, but they will be in the criminal justice system. So they are probably more than likely incarcerated on their way out of the system. And that one's women-based. So we are focusing on women. We do have a women's correctional facility. So what we find is Utah doesn't have a domestic violence screening. So we'll have to kind of develop that to identify women who have been victims of domestic violence, and also screen positive for a brain injury. But that's our focus when it comes to victims of domestic violence.
Theta, I wanted to jump in. Megan is on now, so I'm glad to see that. And Tracy, thank you for jumping in. We did have a question in the chat that said that they didn't see any survivors on your committee. So I was wondering if you wanted to respond to what we are hoping for in the future.
Absolutely, yes. We are hoping for a survivor or two, or it's just been hard identifying them, and we have to. We've talked about a brain injury survivor, but we really like to have somebody who's been impacted by the criminal justice system and domestic violence. So we've discussed how we are going to go about identifying them and getting permission to be able to have them. We found that we can't just send out a request. It has to be a certain way that we do it, but that is our plan. We are planning on making sure that we have that representation.
Thank you, Tracy. Well, I think we can move to Megan's portion of the presentation. And if there are additional questions for Tracy at the end as well, we can take questions for both Megan and Tracy. So I am going to turn the time over to Megan Davidson from the Council of State Governments Justice Center.
Thank you, Zeta, and apologies, everyone. I had the wrong time zone, I think, scheduled on my calendar. So I've been in back-to-backs today, and so I apologize that I kind of threw everybody for a curveball today with the presentation. So thanks for being willing to adapt. So I'm Megan Davidson, and I am a program director with the Council of State Governments in our Behavioral Health Division. And in my primary role, I lead our Stepping Up initiative within the Behavioral Health Division. And sort of a project that came into our wheelhouse that I've been responsible for has really been focused on looking at the intersection of brain injury and the justice system. So I'll talk a little bit more about that project and the work that we've done there. So next slide, please. So to start off with, to zoom out, I guess, in terms of how this project came about. So CSG is the primary technical assistance provider under the Justice and Mental Health Collaboration Grant, as was just discussed by one of our grantees. And so part of what came to happen as a part of our work with BJA, they had requested that we dig into the issue of brain injury and start to do a landscape review to figure out what is happening at the intersection of justice and behavior, or of justice and brain injury, and how the justice system could improve their responses to individuals living with a brain injury. So part of our work involved looking at the literature. What does the literature say about this topic? Of course, consulting with experts on the topic of brain injury, including NASHA, of course, our partners on that, and a number of other subject matter experts to really get a handle on what's going on with this issue and what could we do to improve the way that the system responds to this issue. So we conducted a series of focus groups and interviews with experts on the brain injury side, as well as the justice system side, to really figure out what we could do in terms of recommendations. So the goal of our project was to really understand the landscape across the justice system, what is happening, what's sort of the prevalence, what's the pathway for individuals with brain injury coming into contact with the system, and what could the system do differently to improve responses to individuals living with a brain injury. So that's sort of the origin of the project. It did also stem from legislation that was passed in 2022 that really necessitated the development of first responder training for brain injury. And so as a part of that, this was sort of the first step, or one of the key steps involved in laying the foundation for development of that training and subsequent work in that area. So as many folks I imagine on this call know, one of the things that's important, I think, for us to be thinking about when we start talking about this topic is just the sheer prevalence of brain injury amongst individuals with individuals coming into contact with the justice system. This is something that surprised a lot of us doing the work. Probably not many of you that are more heavily involved in the work, but definitely when we talk to our criminal justice partners, the numbers are, shocking and staggering, and definitely something that certainly require attention. So based on our research and consultation and looking at previous literature, we're looking at about 50% of individuals coming into contact with the system that do have a brain injury. We can move to the next slide, please. So I already talked sort of kind of about the goal of the project and what it looked like, but this sort of restates that. So really doing a landscape review, synthesizing that information into a recommendations document, and that's really where we are right now. So we conducted all of that. We gathered all of that information, we put it together into a report, and that report is really in the final review stages right now, and will be ready for publication in the next few months. So all of that information that we gathered is intended to inform what the field does moving forward. So it's intended, it is targeting mostly CJ professionals, criminal justice professionals, as well as policymakers that are working at that intersection, and to really help them figure out what they could be doing differently. So that report is the primary product of this work, but this presentation and many other presentations that we're doing at conferences, et cetera, will also be a part of that work as well. So next slide, please. The only thing that I would add based on what I've already said around our focus groups and interviews is that we also attended a couple of conferences or where we had stakeholders together to really talk about the issue. And one of those was with co-responder at a national co-responder conference last year, which is focused on, for folks that aren't familiar with the co-responder model, it is where you pair law enforcement with clinicians and they respond to, situation crises in the community. And it's a way of keeping folks out of jail if we can, and certainly getting them connected to needed resources. So we wanted to talk to them about their experiences with brain injury and what the field could be doing differently. That was one audience. So it consisted of individuals in law enforcement and clinicians and talking to them about the issue, as well as one of our meetings that we facilitated as a part of our justice and mental health collaboration work, where it consisted of prosecutors and individuals involved on the court side of the house to hear what they're seeing with brain injury and what we could be doing differently. So that's sort of our methods and how we got to where we are with the findings and so forth. So next slide, please. So our final report really outlines the prevalence and nature of brain injury in the justice system, and as a point of clarity, a lot of times when we're talking about brain injury in the justice system, we often hear TBI, traumatic brain injury. That's sort of what folks think about immediately. For the purposes of this report, we really focused on defining brain injury as acquired. So, really that encompasses traumatic and non-traumatic brain injuries so that we could really cast that broad net to understand, because it doesn't matter necessarily how the brain injury comes to pass as much as it is how it actually plays out for that individual and how they navigate the system and what that system involvement can look like. So I want to just make a note of that definition. And then we looked at pathways to justice system involvement. Why is the prevalence so high? We unpacked that a little bit about that intersection. And then what does it look like for an individual living with a brain injury to navigate the justice system? And, why is this an important issue? So those first three sections of that report are really focused on just drawing attention to the importance of the issue and setting the stage for the recommendations that we generated from there. Next slide, please. So our findings and recommendations strongly align with what NASHA has produced previously and looked at previously with at this intersection. And so they fall into 5 primary buckets. So training and education, screening and identification, compensatory strategies and modifications, referrals and resource coordination. And of course, we also wanted to add a kind of a sort of wraparound area for recommendations. It's about strategies for advancing those recommendations. It's about policies and collaboration and some of that stuff that really lays the groundwork or serves as that supportive infrastructure that's needed to really implement these strategies and make sure these recommendations do go forward. Okay, so we'll dive into each of these recommendation areas a little bit more here. So we'll start with training and education, so we can go to the next slide. So when we talked to folks that were in the criminal justice field and the brain injury field and talked about, okay, what does training look like in terms of brain injury and the justice system? And what we heard a lot is that there oftentimes brain injury modules might be embedded within other training forums, such as crisis intervention team training, other models that we, mental health first aid, other types of kind of behavioral health oriented trainings. We will see brain injury components getting worked in there, but there really isn't a standardized brain injury training model out there for the field. And so we are recommending that, that the criminal justice professionals do partner with brain injury professionals to develop a standardized training model that can either get incorporated into existing training, curricula, or be standalone to be able to be incorporated into the different ways that the different fields, right? Law enforcement, courts, corrections, et cetera. So we recommend that there's a standard model, but then of course it gets tweaked based on the actual forum. Are we talking about law enforcement? Are we talking about courts, corrections? Of course, the actual model itself and the modules are going to differ based on the arena within which it's being implemented. We also recommend cultivating cross-training opportunities for medical and behavioral health staff, as well as your actual CJ criminal justice professionals, so that everyone's getting the same type of training. We've seen that work a lot on the behavioral health side. So mental health, substance use, a lot of that involves cross-training. When we think about crisis intervention team, CIT, that's a real, common model that's been diffused, and sort of leveraging that type of approach with brain injury, we think would be a great way to sort of move this forward. The other piece of training that's important to consider when we're talking about individuals living with a brain injury is psychoeducational resources. So very similar to mental health, when it comes to individuals coming into contact with the justice system, this could be the first time that they're ever identifying or acknowledging the brain injury, or even if maybe it was diagnosed many, many years ago, this may be the first time that they're really getting a chance to get it addressed. So we want to make sure that folks living with a brain injury that do encounter the justice system are provided resources and information about the brain injury and how it might manifest within their involvement in the system and beyond. And of course, connecting those or providing those psychoeducational resources to loved ones of individuals with a brain injury, also important. Okay, next slide, please. And I apologize for, I'm just going to have to touch sort of high level on some of these things, because of course the report is much more detailed. So that's a little bit of my teaser for stay tuned for the more in-depth report that'll be released soon. But I'll try to touch on things as much as I can in terms of being in depth. So the next recommendation is around screening and identification. Of course, it's important that we prioritize, we promote screening and assessment under Stepping Up, which is the initiative I lead, which is really focused on serious mental illness. The same can be said for brain injury. If we don't know what's happening with the individual and we try to treat them for, serious mental illness or some other medical concern, then we could be missing the mark. And so it's very important to assess for the, identify, start with an initial screener, and then and do it universally. Let's make sure we're screening everybody. And then, of course, doing follow-up assessment for symptoms and developing interventions in the same way that we think about screening and assessment for serious mental illness, SUD, substance use, et cetera. So related to that, it's not just about screening to screen. We want to make sure that, data tracking, that we're using that information to not only drive the interventions and services that we're providing to individuals while they're navigating the system, but also to think more globally about how it might impact strategies that we select for our community. So that's what we mean when we say establish data tracking and information sharing protocols, is let's use this and make sure that we're connecting the dots amongst our medical and behavioral health and our criminal justice practitioners. Let's use it for that management of that individual as they're navigating the system, but also let's look at it globally for our community and kind of start to figure out what we might need to be doing in terms of shifting strategies. We also recommend prioritizing screening youth. The earlier, the better, when we're thinking about trying to get folks connected to needed services. And then, of course, when we're thinking about screening and identification, stemming from that bullet around data tracking and information sharing, we want to use that information to raise awareness and reduce stigma. Because as I mentioned, even in our conversations with folks that are leaders in this field, did not necessarily know the prevalence and how serious it is and how it can impact individuals. So that's an important piece. Next slide, please. So, one of the things that we heard a lot through our conversations is, okay, so I might screen and assess, but then what? Then what do I do, right? And so that's a common challenge for our criminal justice practitioners and folks that are running facilities and, running programs. I need to know what that means. What does it mean? And how do I address that? And so we wrote a lot about that in our report. That it's really not necessarily about implementing an entirely new program as much as it is about modifying existing programs, modifying the existing facility, let's say, or the way that you're interacting with an individual, and the modifying, if you have an existing, let's say, behavioral health modality, that you're using with an individual, think about how you might modify that for an individual that is living with a brain injury. Things like slow down your speech when you're talking to an individual, make sure you're providing notes and that you're following up with them, and they might need reminders and those types of things that, we don't, sure, we could go and certainly encourage them to do some of the stuff we're going to talk about next around referrals and getting them connected with resources and so forth, but making sure that we're really modifying even just the physical environment. If we're talking about potentially corrections, the correctional environment, can we dim the lights? Can we talk slower? Can we take a moment and think about what's happening with the individual? Those are the things that we're really encouraging. And then not only thinking about how we can adapt the environment and programming for individuals with a brain injury, but also helping, empower individuals living with a brain injury to figure out exactly what sort of symptom management strategies make the most sense for them. So that's where it's really a partnership, right? Where we really want to make sure we're connecting those dots and it's not just us dictating what we think is best. We really want that to be a partnership there. Next slide, please. Okay, so this is where, a lot of what we promote in terms of the system reform efforts is really around making sure that folks are getting connected and necessary resources. Well, the same is true if we're talking about an individual living with a brain injury. As I said, we think about a lot of this with serious mental illness and SUD. The field has come a long way with addressing those issues. And the same types of changes are needed when it comes to individuals living with a brain injury or thinking about brain injury a little bit differently and recognizing that issue. So we want to establish partnerships and referral mechanisms between criminal justice entities and brain injury service providers. We know that not all behavioral health service providers will be able to serve somebody living with a brain injury, that there might be additional needs and, modalities that might be needed for that individual, additional supports and wraparound services that might be needed. But we really want to make sure that we're identifying what's in the community that we can partner and leverage and so forth, and making those appropriate referral mechanisms. So if we're talking about an individual that's on probation or parole, community corrections, let's try to get them connected with services in the community that can help them with that. And then the same with reentry when we're talking about individuals leaving custody, getting them connected with needed resources. So just factoring that in. We know the field has come a long way when we think about reentry, for instance. But brain injury might not be on the radar of individuals that are reentry specialists. I mean, we really need it. It needs to be, is one of the key points. And then, that care coordination is another important piece. So just making a soft referral may or may not manifest into somebody getting the help that they need. So one of the things we talk about in the report is neuro resource, facilitation and really that wraparound, the importance of case management, care coordination when we're talking about an individual with brain injury, to make sure that they're getting connected to those services, because they may not be able to track the appointments and be able to figure out, how to navigate some of those situations. So they just might need some additional support there. So making sure that that's in place to really set them up for success. Next slide, please. So our last area of recommendations, as I mentioned, is really around the infrastructure. So, it's interesting because in any of our conversations, I will just tell you all sort of anecdotally that the field is really interested in, the criminal justice field is very interested in what this could look like and how we could change the field in this way. Even though we know there's pockets of the country that are already doing that. And that's in large part to probably many of you that are on this call, quite frankly, and many of the folks that we talk to through our conversations. But just making sure that even at the local level that we're establishing collaborative partnerships, local, state, national level, building those collaborative partnerships between brain injury experts, advocacy groups, et cetera, brain injury networks, and your criminal justice entities. Building those partnerships is essential to really figure out what a shared system and referral system could look like and how we can support one another. Promoting that positive culture shift around, and this goes all the way from law enforcement through corrections, thinking about individuals thinking about that behavior that might be manifesting and thinking about it differently. What is it that is playing out here? It could be a number of things. It could be SMI, serious mental illness. It could be SUD. It could be brain injury. It could be a number of other things, quite frankly, or it could be a co-occurrence of many things. But just thinking about the humanistic side of that and looking at a person holistically as to what they might need. Applying a racial equity lens to what we're doing here, of course, making sure that if we are establishing partnerships and building systems, how can we make sure that's equitable for everyone in a community? We also encourage states, jurisdictions, localities to look at their policies and legislation related to brain injury and what changes could be made there to make sure it's supportive of these other recommendations that have been outlined here. Increasing funding opportunities for research on this topic. There are many folks that are doing great work in this space, many of whom we got to talk to. That was our honor to speak with many of those folks that are doing that work. But it is still a relatively understudied area and an area that needs more funding for research, but also for just the supports and the connections and training and et cetera that we've already talked about. Okay, next slide, please. So that's the recommendations that we, at a high level, many of the recommendations that we generated and that will be contained in the report that is going to be forthcoming. And in terms of next steps for us, what we're looking at is partnering with BJA, the Bureau of Justice Assistance, to determine how to best get this information to the field. And also our brain injury partners as well to see, okay, how do we want to do this in different presentations such as this one? What's the best way to get this information into the field that's outside of just a report, right? We want to make sure that it really has some legs. Leveraging partnerships, again, to really advance the recommendations and bake this into the work that we're doing within the Justice Center and beyond. Our partnerships, really making sure that brain injury starts to be a little bit more embedded into the work that's happening. And as I mentioned, there's an opportunity probably for us to be developing additional resources that might be specific to law enforcement, jails, courts, et cetera. The report that we have produced that's getting ready to make its debut out in the world is focused more broadly on the justice system, but we do have an additional set of recommendations specifically for law enforcement and jails and so forth. So we have to figure out how we want to get those out there. So that's a summary of our project and the work that we've done to date, our planned work for the future. And I'll turn it back to you, Zeta.
Thank you so much, Megan. That was wonderful overview, and we are truly grateful for our partnership with CSG and putting together this report and your leadership on this. I think we have a few minutes for questions. I know that Judy has been monitoring the chat as well, but I'm just going to start with one that I saw from the group asking about, and I think this could be for both Tracy or Megan, if you are hearing from other states who are looking to take what Utah has been able to do and apply for the Justice and Mental Health Collaboration Act or some of the other funding available from the Department of Justice that is focused on brain injury.
You know, maybe Zeta, I'll jump in on that.
Yeah.
Judy.
And Megan, if you've heard of other folks as well.
Sure.
First, we're really grateful to the effort that has happened with the Bureau of Justice Assistance through your work, Megan. I think it really has helped to highlight this intersection of brain injury and the justice system. So at the National Association of State Head Injury Administrators, NASHA, we do have a Leading Practices Academy on criminal legal system. That's the terminology we use for that instead of the criminal justice system. And we've had this going for, this is our 4th year, and there's been several states that have been engaged in that. And each one of them has some kind of variation on this theme of what Tracy is setting up in Utah. But I do think that what Tracy's work is, and Tracy, feel free to jump in if you want to expand on this, it is a little bit more broad and expand it from some of what other people have, because she has such great funding streams in her state. So it's a little bit more comprehensive than some states are able to pull off. But if people are interested in exploring what states have these, just please reach out to me. I'll put my name and email in the chat, and I can share with you what's happening in the country. There's a person out of North Carolina at the Disability Rights Network in North Carolina who's developed a database related to justice projects as well. So we can I'll try to put that link in the chat. Oh, thanks, Terry, for putting my email in the chat.
And
So there's several states at this point trying to work on this.
as states are seeking funding, both of the solicitations that we mentioned that mention brain injury are out and open right now. So if states are looking to expand those, there is funding opportunities from the Bureau of Justice Assistance to try and expand that work. And I'm happy to talk with folks about that as well. I can put my information in the chat too.
One question that came in at the very end that I wanted Megan to respond to before I lose that question is where will people be able to find this report once it's completed?
Sure. We will definitely do some promotion on our social media for sure, and it will go on our website, the CSG website, the Council of State Governments website, and I will also be sharing it with our partners that were involved in the work, which I want to acknowledge and just share how much I appreciated the opportunity to meet many of the folks many of whom I've seen in the chat and I think are attending today, that it was such a great opportunity to meet everybody that worked on that. So we'll share it with everybody that was a part of that, including NASHA, and they can distribute amongst their networks as well. It'll go out through our newsletter. If you're not familiar with our behavioral health newsletter, please hop on the Council of State Governments and sign up for that. We release a lot of our resources that way. So it'll go out, I imagine, in a number of different ways, and possibly through BJA as well. But we'll make sure that the link is out in the world once it is ready.
Great, thank you.
Sure.
Tracy, one question that came in early on was just a question related to connecting with families with children or adults or minors who are harmed through through domestic violence or child abuse that have aggressive behavior or disability as a result. In the work you're doing in Utah, will there be efforts related to the whole family, or is there a plan for that?
That's not part of this project, but we are aware of that. We do work on our juvenile justice. In our juvenile justice, we do have a pilot going out that's screening kids for brain injury, and we're sending home or sending the parents information on how they can contact our resource facilitators, who can then help support the families. That's how we do that. We'll get them connected to whatever services we can, but that's the only I guess justice involved things that we're doing as far as that is concerned. So.
Great, thank you. A question that was just generally put in the chat, and if anybody wants to jump in on this, please do, but It was, what does domestic violence mean to people with disabilities? And I will just kick off that answer by saying there is a high correlation between a higher incidences of domestic violence for people who have experienced disability. So those two things are pretty linked, and a lot of states actually have some domestic violence services specifically for people with disabilities. Does anybody else have anything they want to add to that piece?
The only thing I would add is that we certainly saw that come up in our work, that, you know, it's a point that we make in the report, and that we're certainly encouraging, or just sort of opening eyes to that when we're talking about, you know, women that are coming into contact with the system, that let's, you know, if they've been victims of domestic violence, let's make sure that we're really having an open eye to that. So it's just something that definitely was emerged through our work that we're also flagging for the field.
That's great to hear. And then kind of a different variation of this question, but a question was asked, and it was noted that people with intellectual and developmental disabilities often struggle in the criminal legal system, as do people with brain injury. There's a lot of parallel there. So any work being done to address that at your level, Megan, and anything you're aware of?
Well, I'll say that it gets talked about a lot, and I will say that we know that there's training modifications with, for instance, crisis intervention team, CIT. I think, Judy, you've been a part of some of that as well, of developing training for our first responders and you know, folks that are working in the system around IDD, DD, et cetera. There's folks doing sequential intercept mapping, looking at resources and trying to figure out exactly what are service gaps and how could we do the referral piece that I talked about, looking at that for IDD, DD. I'm not aware of a similar project that tackles that, but I will just flag, not to open a whole other can of worms necessarily, but I was talking to a jail administrator the other day about this work, and one of the things that came up is that he's working with his geriatric population, and he's interested in some of these recommendations that it could apply across, you know, geriatric folks that are coming into contact with the system too. And so I think that some of the stuff that is contained here, not that it's, you know, fully going to solve all of the world's problems as much as we wish it would, is applicable across these different groups of individuals, or individuals with different circumstances. But it's definitely, I will say that it is on the radar of our federal partners, and certainly on our radar.
Yeah, that's great to hear. I'll say that at NASHA, we've been collaborating a lot with the National Association of State Directors of Developmental Disability Services, as you'll hear from them later, a little bit on this issue, because we do recognize that parallel is there between IDD, brain injury, autism, I'm sure other disabilities. So yeah, it's a big issue to tackle, but some of our resources could benefit each other. One question that came in is, how did you differentiate between mental health disabilities and traumatic brain injury in screening and identification? So Tracy, do you want to talk about the screening that you're hoping to implement and what that captures?
Sure. We're hoping to implement the online, the OBIS, the online brain injury screening and support system. Did I do that right?
You got it.
Woo! And that screens for a lifetime history of brain injury using the OSU TBI ID, which is a, I don't know, help me out with that, Judy. It's a
screen for a lifetime history of brain injury.
So that's how we will determine. And then we'll just, yeah, that's what we're hoping to use, is that screening, and that's how it will be determined.
And I see Maria put a link to OBIS in the chat if you are interested in learning more about that. But I do think that is exactly what people, when we talk about how you differentiate, it's very hard to differentiate what is happening, to know if it's related to the mental health issue or if it's related to the brain injury. But oftentimes people aren't even screened to see if they have a lifetime history of brain injury. So the Ohio State University Traumatic Brain Injury Identification Method is an instrument that allows for that. And OBIS combines that along with a symptoms questionnaire to try to get at what Megan said, which is, now what? Now we know they have a brain injury. How does it affect them? How does it affect their functioning currently? And what are those strategies we can put in place to help support them? And so it incorporates kind of universal strategies that are helpful for anyone, honestly, going through the court system, but definitely necessary for those with brain injury. Okay, thanks, Tracy. Tracy, another question that you might be able to answer, and I don't think it necessarily engages or involves your justice system grant, but in Utah, are you connecting to veteran providers?
Sorry, yes. So we have a polytrauma unit, a veterans polytrauma unit here in Utah. And yes, we do engage with our veterans. We don't get a lot of, what do I want to say, referrals from veterans, but when we do, we do. We have a couple of our veterans with lived experience on our brain injury advisory board. So that is something that we try to tap into. So yes.
That's great. Thank you. I'm just doing a quick perusal here of, I see some comments about, people with brain injury or other disabilities who maybe have a lack of trust in the justice system because of past treatment. And definitely that is understandable. So I think that the work that you're doing, Megan, related to this project, and just all of us doing this work to elevate this issue and help bring awareness, is going to help in the long run. But there, it is a challenge at this point. And we know of several cases where people have experienced some injustice in terms of their connection to the system. It's just something that I think will take a while for education to catch up and for people to be able to have better experiences.
Megan, I know that you, in the report, it talks about all of this activity related to brain injury being done in a trauma-informed way. And oftentimes, as we know, since brain injury is something that happens later, it can happen later in life, there's often trauma associated with it. So I'm curious if you can just talk a little bit about your approach as you're developing the report related to ensuring recommendations or work is trauma-informed.
Yeah, I mean, I think that this sort of ties into what Judy was mentioning too, and that, the training piece is so important, and just the framing and the culture shift that we wrote about, and that, we really are encouraging, because it is, if you have a broader trauma-informed approach to the way that you're doing your work within an organization or within a program, et cetera, within a system, quite frankly, then you're going to have such a better approach in general to how you're managing any of these issues, right? Whether it be trauma, just generally trauma of a life event, or traumatic brain injury, any sort of other subsequent, issues that might be going on with an individual. So very much think that the piece that I was talking about around culture shifting is something that is connected here, and encouraging communities and organizations to be thinking about that culture shift. And I think that is achieved through training. And we talk also in the report about leadership being a key part of it, that there has to be leadership buy-in for us to see this change and the uptake on many of the recommendations that we suggested too.
Thank you. I think we do have a few more minutes. So if folks have additional questions, you can put them in the chat. In the meantime, I think I have a couple more questions we can ask the group. I think really for both of you, some of our listeners today are state brain injury programs, and So I'm curious, Tracy, from your perspective in developing partnerships with your criminal legal system partners, how you've been able to do that successfully. And Megan, if there are any best practices or things that you heard from the report about how state brain injury programs can partner with their other state criminal legal system agencies or others in the community.
I would say and I don't know, maybe I look at things a little bit differently, but for me, it seems like everyone would just kind of was like, yeah, we know it's a problem, we know, and so we've just kind of naturally built those partnerships. It's very difficult to kind of pinpoint. Though the white paper that was written was helpful. And when that was, dispersed, some people were like, yeah, we know this is a problem, so that was helpful in getting our Department of Corrections kind of involved. But as soon as we started talking about, brain injury in this arena, people were like, yeah, we know it's an issue and we want to help. And so sometimes it was just a quick conversation that says, hey, here's a white paper, or hey, this, and people were like, yeah, we know. So that's kind of how it works with us here in Utah.
So a couple of ideas that I think, you could explore is where there are existing work groups, cross-discipline work groups, committees, et cetera, that might be appointed or just convened, right? Because we're talking about, like, again, I referenced behavioral health, and there's a lot of that happening, right? Where you've got cross-system partners coming together, and brain injury folks may not be at the table there. And so I think that's a great way to sort of to start. That's a great way to get in the door, is if you can get on some of those committees or get on the agenda for some of those committees. That type of thing could be a great way to sort of dip your toe in. Because and also I would certainly encourage direct outreach to different, criminal justice agencies in your area. But one way to sort of soft pedal that is to get on the agenda of different committees and so forth, where you can start to kind of plant that seed that might need to get a little watered, right? If folks are not fully on board, that's a great way to just get a seat at the table. And then start to nurture that and look for opportunities to collaborate and start to kind of catch momentum there. And then if you're hosting an event locally or at a state level, invite the criminal justice folks to the table. Make it, have a session that's specific to them. Try to, open that door so that they see, okay, that's an opportunity for me to come to this. So those are a couple of things that I think you could explore in addition to, cold outreach, right? That may or may not produce change, but sometimes it is the cold outreach that gets you there. I've seen that happen in different places too. So there's some different strategies that you can use, but I think leveraging some of the cross-system partnerships that are in place between medical and criminal justice professionals, between behavioral health and criminal justice professionals, addiction, and substance use professional, trying to kind of get in those different networks is a great way to sort of, I think, just get a foot in and start to build some of that collaboration.
Judy, what would you add?
Yeah, I was just saying, I think those are great suggestions and practically how it comes together, Tracy. I always encourage states to pay attention to any kind of policy or legislation that's happening in your state to see if you can leverage that. And I will say, when it comes to brain injury, it's typically connected to behavioral health. So if you see some initiatives in your state to improve behavioral health outcomes, you can then make an argument that brain injury is really linked to those who have behavioral health. We know that data is as high as 80% in terms of that correlation between those who have brain injury who also have behavioral health issues in a justice setting. So it's really, they're very close. So that's one thing I would say, kind of get to know your departments, your state departments, to see where their energy is going with this and get to know them. I mean, Megan, your point is perfect. Like, get to know those committees, get on those committees. So they know you when the opportunity comes up. I wanted to ask Tracy, oh, go ahead, Tracy, you're gonna answer that.
I'm sorry. I was just also going to mention what really helped, just a couple of things. And I don't know if every state has this, but each of our departments have a legislative liaison that work with legislatures on, and I honestly believe that that was very, very helpful in both of our Department of Health and Human Services and our Department of Corrections. We had two previous legislatures that are now that liaison from the state to the legislator that were champions of brain injury. They helped with both of our funds, getting them established. And they also helped us get, speaking of, policies, and that policy with our road rage has come through, and they added in any impound fees or all of that due to road rage would go into our brain injury fund. So, watching some of those things also can help with some of that advocacy work.
Excellent point. Tracy, someone had asked if you'd be willing to share the white paper, and if you are, Jill Farrington says she can post it for us because we have a link to it. Okay, Jill, please do post that white paper. Thank you for that. Okay, sorry, one more point that was made really early on, and I apologize, I missed it, but it was about housing and people with brain injury and the challenges around housing. That's another population that is so linked when we talk about the justice system, brain injury, how those who are experiencing a lack of housing. So I guess just a question, I don't know if there's any initiatives people are aware of as it relates to housing and brain injury in this criminal legal space.
Yeah, I mean, it's definitely a great point and something that absolutely it's critical that we think about it from that perspective too, especially when we think about reentry. I think is a key piece of something to really keep in mind. So because housing and placement and et cetera, there's so many criteria around some of that. And so partnering there and thinking about how to reduce those barriers and expand criteria or train, accordingly, is just something that's so critical. We do have a housing team within our behavioral health division that we will be coordinating with to sort of see if there are ways for us to partner with some of the recommendations that we produce and some of the work that they're doing to see if there's sort of a braiding of work that we can do to help the field move along. But I think the piece that is so obvious to me, I guess, in terms of action that might be needed is thinking about those barriers, those housing barriers, even in screening criteria, and just the professionals thinking about those barriers, which we hear a lot about for mental health as well. But just that's one of the things that I think about a lot when I think about that intersection and what we could be doing to address that.
Yeah, that's great. I think that the strategies are very similar to what we're talking about with people experiencing brain injury in the justice system. I will add that the Administration for Community Living, along with HUD, is collaborating to put together a webinar on housing and brain injury for housing service providers. So that's exciting. That's a great start in terms of some of this communication. And eventually there will be hopefully a website resource kind of, I guess, repository for information related to housing and brain injury. So I'm hopeful. There's some really good pockets of activities going on around the country around that issue. Some states that have taken on that challenge and have begun working on that. But it's also very exciting to see now that at the federal level, that conversation is occurring. I see someone asked about the housing webinar. It's not my webinar, but we'll see. I don't know if Sean, if you have thoughts on that, or Elizabeth, if you're on the call as well. So we'll get back to that question throughout the day here. Seda, turning it back to you to wrap us up.
I think we have just a couple more minutes before we move to our next session. So I think it might be helpful maybe if Tracy, Megan, do you have any final thoughts or things you'd like to share? And then I can wrap things up.
I'll just share really quick, just to keep at it, I guess, and find any connection you have. I took a course, and it was a state public manager course. And in that course, there was somebody from Department of Corrections, and we kind of built a relationship as far as, you know, we know each other, and just those little tiny things can help start those relationships and just the talking. And that person is now a part of our steering committee. And so I would just say, just any little, those partnerships are important and will help move your work along. So that's all I would say.
Thank you, Tracy. That's great.
Relationships are great. It just starts with relationships, and that's really how the change happens. And I think the only other thing I would add is just what an eye-opening experience this has been for so many of us that worked on this project, and for many of the partners involved on the criminal justice side. And I'm hopeful and optimistic about the uptake of the recommendations that we were able to pull together. And just very appreciative for all the folks that we got to work with on the project. And you know, I think it's been really well received, let me say, so far with BJA and our other partners. So yeah, I think it's definitely an important issue. And when we think about change happening, it starts with that awareness piece. And I think we're there, right? I think we're really there, and some places are much further along, and we look for opportunities to learn and foster those peer learning opportunities as we move forward.
Thank you so much, Tracy and Megan, for joining us today and for your leadership in this space. We are really excited about the many opportunities that can be leveraged from both of your great work. And thank you to ACL for providing an opportunity to share some of the work that is happening. So I think it sounds like we're going to take a break. Judy, am I turning it back to you to?
Yeah, yep. Thank you, Zeta, so much. And thanks for facilitating the conversation today. We really appreciate your participation as well. We will be taking a break until 1:35 Eastern time, so 35 minutes after the hour, whatever your hour is currently. So please come back at 25 minutes before the hour. And Terry put the time zones in the chat, but I know we have someone from Hawaii here, so you'll have to do the math because that's a tough one. Anyway, thank you all, and thanks for that great session, and we'll see you all back here 35 minutes after the hour.
Welcome, everyone. And that was an outstanding presentation, just very informative that we just heard. We are now into aging with a brain injury. And so we have, and we can go to the next slide, Vivian. We have 4 presenters for this particular session. We have Dr. Monique Papados, who serves as Associate Professor and Vice Chair of the University of Texas Medical Branch. We have Joseph Lugo, who is the Director of the Office of Network Advancement for the Administration on Community Living. We have Martin Kerrigan, who is a TBI survivor, educator, advocate, and professional, and also serves on the TBI Advisory and Leadership Group. And also we have Ann Zuckery, who is a TBI survivor as well. She's an author, speaker, educator, and also a member of the TBI Advisory and Leadership Group. Now the TBI Advisory and Leadership Group is a part of the Technical Assistance Resource Center, and also is funded by the Administration on Community Living. So first of all, we'll go to the next slide. We will introduce Dr. Monique Papados. Dr. Papados, are you there?
Yes, I'm here.
Thank you.
Annotate button. Mute.
Sorry. Joe, excuse me.
We are ready. Monique, Dr. Papadis can come on now.
She said she was ready.
Yes, she's ready. And just let us know if you want us to move to the next slide, Dr. Papadis.
Okay. Hello. Thank you. It's an honor to be here. Excuse my voice. I have been ill for the past few weeks, so it may go in and out. Excuse me. And so today I'm honored to be able to share about some of the work that I have done, as well as my colleagues that have explored kind of the experiences of older adults living with traumatic brain injury, as well as individuals of any age aging with brain injury. Next slide. So as I kind of just mentioned, one of the things that I have to acknowledge is that older adults is a growing population within the U.S. And so earlier on, there was, if you look to the left, kind of this almost like a pyramid that shows how in 1960, most of the population was young children, and then as well as middle-aged individuals, and very few older adults, especially in the ages of 80 years and older. But the projections of what we see, we know that just from the most recent census is that older adults make up about 1 to 5 ratio out of the current U.S. population, and it's expected to, decrease from that to anywhere from, 1 to 4 adults in the U.S. Being older adult. Next slide. And so in this slide here is just to give you kind of a snapshot. This is from data from the CDC related to how older adults is, growing among the TBI population as well. And in 2016, as well as data from 2017, as you could see here, it essentially shows you that older adults, particularly those 75 and older, are experiencing an increase of TBI-related hospitalizations and also deaths in comparison to younger children in middle age. And so, previously, many younger adults as well as adolescents were often the largest population that experienced traumatic brain injury, and now there's this, increasing incidence of older adults sustaining brain injuries. Next slide. So most of the older adults, the kind of key mechanisms of injury and how they sustain their traumatic brain injury are often these three. These are kind of the top three causes of injury. As you see to the left, accidental falls, which is the most common reason for having sustaining a traumatic brain injury as an older adult, as well as motor vehicle accidents, which is similar to the younger population, and then being struck by an object or against an object. Next slide. So many of the, there are a number of different consequences that individuals may have after having a traumatic brain injury. And this is not an exhaustive list. This doesn't indicate that every person has all of these consequences of their injury, but this is just to give you a picture that there are physical changes that can happen, such as with balance. Headaches are quite common after injury. There are changes with cognition, where you see changes in attention and memory. And then also you may see changes in emotional aspects of emotional functioning, such as things such as anxiety and depression. And those two often co-occur after having a brain injury. And then lastly, you may see behavioral changes after injury, such as things as apathy, changes with initiation, and self-regulation. Next slide. So when it comes to, when you think of older adults, oftentimes older adults are having to manage many chronic conditions. Even prior to sustaining a traumatic brain injury, older adults are managing a variety of different chronic conditions. Many individuals have more than one chronic condition. And some of the work, I mean, this is emerging area in the field of traumatic brain injury research, that some of the findings have shown that as many as 70% of the individuals that have been surveyed who are older adults have at least one chronic condition. And so what are those types of chronic conditions? Again, I have to preface that this is not an exhaustive list, but these are some of the ones that are quite common. And some of these, as you can imagine, they're quite common just in older adults in general who have not sustained a traumatic brain injury, but we still see these occurring with individuals, after having a brain injury. Things with like cardiovascular conditions, which is generally the top one that many individuals are experiencing. Hypertension is very common after, among older adults. And what we've seen is that it's common among the population with traumatic brain injury as well. Diabetes, diseases of lipid metabolism, such as high cholesterol, musculoskeletal diseases, osteoarthritis, which is again quite common in the general older adult population. Things like pulmonary diseases and fluid and electrolyte disorders, as well as stroke. There's been a lot of research that has shown that stroke often can co-occur with traumatic brain injury. Oftentimes individuals have these underlying cardiovascular conditions that put them at increased risk for sustaining a stroke after injury. Next slide. So as you can imagine, just managing so many different chronic conditions can impact, engagement with the healthcare system, engagement with just long-term recovery after traumatic brain injury. And so some of the research that colleagues often who are affiliated with the National Traumatic Brain Injury Model Systems program have explored how individuals with chronic conditions often have increased visits to emergency rooms, right? And often readmissions. And these readmissions are often due to, challenges with managing a lot of these chronic conditions after their injury. And then also with being institutionalized and increased risk of institutionalization due to, just not having support, the decline in health, increase in due to these chronic conditions and overall health that may decline. And so there's a need for individuals to be in long-term care supports and outside of their home and outside of their community. And then again, these chronic conditions, we see over and over in the general population, as well as some of the limited research and among populations with traumatic brain injury, is that having all these chronic conditions also is associated with, these poor outcomes, such as reported poor quality of life, mental health, as well as physical health. Next slide. So a lot of, there has already been several recommendations how to manage this kind of thinking of long-term management of one's health after traumatic brain injury. Some of the things that have come out of many of the work that has been done with the Galveston Brain Injury Conference, as well as the Institute of Medicine, which is now the National Academies of Medicine, Engineering, and Science, and to look at and focus on that we need to have better surveillance systems to be able to monitor and identify kind of one's health and conditions that individuals may have long term, the timing, when individuals are seeing primary care, when they're seeing specialty care for these conditions, for example, seeing cardiology to manage those cardiovascular disease, and neurology to manage those vascular or conditions, neurological conditions. And so the timing is important. Being able to maintain and continue a relationship with providers to be able to appropriately manage one's health, identifying preventative interventions to help reduce the risk of negative or adverse consequences for not being able to manage one's health, being able to support and train individuals how to do it, how to manage one's health. And then access is a big issue, especially for individuals, people of color, people with limited English proficiency in the U.S., individuals with limited resources, financial resources, underinsured or uninsured. That ability to access medical care, ability to access rehabilitation services to help improve function after injury. And then just having a system that's integrated, right? Being able to communicate, the communication between healthcare as well as community systems, community services that are in the community, and have a partnership. You've heard that word quite often thus far today, and I'm sure you'll continue to hear it today, is the need to have that partnership. Next slide, please. So I always show this, and I must say that, my great colleagues, Dr. Flora Hammond and Dr. John Corrigan and their great team, they're developing a chronic care model for traumatic brain injury. So I'm going to show you the original chronic care model that has been applied to many, many populations. And so I use it in my work to really understand, as I began to study older adults, the care that they receive, and looking at the healthcare system and how they engage with the healthcare system, and all the supports that they need. They need community supports. They need, again, as I mentioned, self-management, delivery of these healthcare systems, decision supports, and the IT clinical information systems to make sure about managing, monitoring, and surveillance, for example, and how that all interacts between the patient, the individual being informed, being empowered to take care of one's health, as well as having a supportive team that's proactive and not reactive but proactive, and having that interaction to help overall improve health outcomes. So more to come with this, as far as really all the work that's currently underway with trying to develop a model that's geared for individuals with traumatic brain injury, making sure all that are included, as well as acknowledging the wonderful support that many caregivers, how they play a role in this management of the health of individuals with traumatic brain injury. Next slide. I just want to briefly show this because I always show this since the NASM published this in 2022, because it's how I view everything, from the incidence of traumatic brain injury and all the biological, the psychological, the socio-environmental factors that play a role in how one engages their trajectory and recovery after brain injury, their engagement with the healthcare system to help manage their health, and then how all of that, all those external factors, internal factors play a role in how, long-term recovery as they progress. And again, there's always this constant engagement with the healthcare system across the lifespan. Next slide. So for my particular work that I'm doing, I must indicate that it's specifically focused on the Texas Medicare data, but I will also present data or results and information about some of the other work that we've done using kind of national data, using National Traumatic Brain Injury Model Systems projects, to help us with, getting to this point of, further exploring the health of individuals aging with brain injury. And so for me, this model just essentially just to show you that, I'm really interested in all these, personal, interpersonal, environmental, social, geographical location of how all these factors play a role in, engagement with your primary care, access to primary care and specialty care, access to rehabilitation services to address many of those, changes in function, changes in mental and behavioral health, and how they impact overall health outcomes. Outcomes such as, satisfaction with life, perspectives from healthcare personnel in the system, as well as looking at those kind of longer outcomes of, whether or not individuals are having increased access to or needing to go to the emergency room, readmission, being institutionalized, or experiencing death. Next slide, please. So here, as you can imagine, there's so many different points, from emergency care to acute, going to rehab. Not everyone has the wonderful opportunity to go to rehab, but they may receive services later on, or they may, benefit from services that are identified within their community. Some individuals may have to go to a nursing home, like many older adults. And then unfortunately, there's a small percentage of individuals that have to receive hospice care after injury. So along these points, there's different, experiences with access, even within each setting. There's variation in the experience and the care and services that are received. And so, understanding as individuals are, living with these chronic conditions, how, they're engaging with these different systems at different points after their injury. Next slide, please. So in my work in Texas, as you can see here, this graphic is kind of just showing, I was really interested in seeing after having a brain injury, how many people can return home. And so as you could see, we followed individuals from their being discharged from their initial hospitalization for brain injury. And so, there's about nearly half of those individuals will not receive any care. They just go straight home. Then you have some individuals, older adults, who, the next top is the skilled nursing facility, followed by inpatient rehab, followed by having to be transferred to another hospital or care facility. And then you have those individuals that have to go into a nursing home. And so over the time of just following individuals for about 20 weeks, you can see this kind of shift in, kind of where they are. And so over time, for those that do survive, they are able to, about 80% by 90 days post-discharge, are able to at least return to their community. Next slide, please. And so these are just some of the key factors that I found. We found different social determinants and that impact or kind of differentiate those who are able to or more likely to be able to return to their community, having a primary care provider and what's that role, and then having a previous history of traumatic brain injury or greater severe injuries reduce that likelihood. Next slide, please. Here's similar what we found related to readmission. And again, there's these, depending on individuals' health, may put them at greater risk for readmission. Also, individuals of minoritized backgrounds had an increased risk as well. The role of the primary care provider is interesting. We think it's just, those individuals that have a lot of conditions who are seeing and maintaining primary care related to having an established primary care provider, maybe, kind of more on it possibly, and that may be able to, may be able to have, more kind of health concerns or conditions. Again, this is kind of maybe a proxy for that associated with readmission. Next slide, please. Okay, and so this is just a snapshot to give you a picture of what's happening. As you can see, many older adults, there's many older adults before their brain injury didn't even have a primary care provider or didn't see one. Let's say that, didn't see one. and then afterwards, some individuals had as many as over 10 10 primary care visits. To the right, you kind of just see over time, like when do people start seeing their primary care provider if they had an established PCP prior to their injury and seeing that same provider. As you can see, there's, some individuals see them as early as within the first week to individuals really not seeing individuals until much, months and later after they're being discharged home. Next slide, please. And then just briefly, I think I'm getting close to over my time maybe, but just briefly, we've also looked at health literacy and how does that impact, outcomes. We saw differences by education, by race. We know that health literacy may impact perceived health and mood, depression after having a brain injury. And then we did see that older adults, again, were more likely to have more chronic conditions. And then those that had greater chronic conditions had decreased mental health. And so then to the right, you just see a snapshot of kind of where people are based off of a health literacy measure, with most of them being considered adequate or having health literacy, and then others that may need some more support with health literacy. Next slide, please. And then we've done some work looking at, kind of a snapshot of the literature on self-management interventions, their overall effective, improving quality of life, hope, functioning, reducing pain, aspects of disability, and so a variety of things. And so, but there really hasn't been that much work looking at self-management interventions for people with TBI, specifically making appropriate adaptations and considering any cognitive impairments that may be associated with their injury. Next slide. So to end, some kind of future considerations, I have to always emphasize that there are great guidelines for individuals in that acute point of view, in the acute care setting, in the trauma care, but there aren't really clear guidelines on how can we best support older adults with traumatic brain injury for their long-term needs, and to guide practice. So much more work to come with that. Again, even with individuals who have even similar and same state, same insurance, still disparities exist with access to primary care, post-acute settings, community-based settings, and differences in outcomes as well. Again, there needs to be a partnership, right, between primary care and specialty care to help with, managing chronic conditions, but also with TBI-specific providers who have that expertise, and forming a partnership so that we can better support individuals with brain injury and their families. And then at the end, again, just need for a chronic care model, interventions that can improve health literacy, and individuals to be able to appropriately manage their health to reduce any of those adverse outcomes that I mentioned previously. So I'll stop there. Thank you.
Thank you. So just a couple of seconds, we're going to go back to Joseph Lugo's slides, and then he can get started. Thank you. All set.
Thank you, Monique. That was some rich information. I can't wait to get a hold of that slide deck. Thank you so much. So this is going to have a little different feel, but hopefully just as relevant. Hi, everyone. I'm Joseph Lugo. I'm director and lead our Office of Network Advancement. I tell people I have the best job at ACL because our team, we spend all of our time and all of our energy trying to focus on one central question. How do we help the actual organizations within our network sustain, grow, and enhance their organization and their workforce so they can reach more people, fulfill their mission? And so we feel kind of like if the organization's not healthy, then we're not going to be able to reach all the individuals with the needs that they have. And so that's what I enjoy most. And so the next slide kind of walks us through how we're going to try to use our time today. I'm going to start with this about love it or list it and talk a little bit briefly just to set some context, just to help level set on healthcare and social service alignment from our perspective, and what does that mean and how does that impact what we're doing. Next, we're going to talk about kind of like, are you in the game? What is access? We're going to try to define our terms and really going to help level set in terms of what are we talking about when you say access? What do you mean when you say no wrong door? And then finally, I'm going to close probably with the most important question that all the speakers really today have to address. And that is, with all the other competing demands that you have, so what? Why is it so important? Why should you care about this topic? And hopefully you're leaving with one or two kind of key tangible action steps that you can consider after this call, after this day. All right, if we go to the next slide. All right, now we're going to have a little fun here. This is playful, I admit, but trust me, there's a point that I really want to drive home at the end of this slide. So on the screen is a sample of the types of home makeover shows that you find on TV right now. And so if you have a favorite or you feel compelled, feel free to drop that into the chat. Personally, I like it, love it, or list it. It's a weird thing where they remodel the house and then they go look for a house and then they have to decide, do we stay and love it or do we list it and move on? But you may have others. But what I'd like us to do as a group, yeah, I agree, fixer-uppers, those are all good. feel free to drop those in. So what I'd like us to do is imagine that Health and Human Services, a federal agency, imagine it being an enormous home or this physical house, okay? And then next, I'd like for the group to try to imagine that different parts of this house represent different aspects or programs within HHS. Now, you may get a sense of where I'm heading with this. I would argue that human services, the work that we do day to day that we love, would be the kitchen of the house. It's the focal point of the house. It's where you spend most of the time. And many times it decides whether you're going to buy the house or not, is the kitchen. Now, the point I'm trying to drive home is this. If you look at HHS collectively and how it's allocated resource in terms of the health side and the human services side, I feel like every part of this house has been remodeled with the exception of the kitchen. And I feel like we are 50 years overdue for an upgrade and an investment in terms of human services and what we're doing. So today I'm going to be talking about how to improve access to the kitchen, but there are other efforts that we are doing, even within our own office, that are trying to help align healthcare and social services. One of the most tangible are community care hubs. We don't have a lot of time to jump into it, but it is a real effort that we are working through on how we can reinvest into human services and how we can increase the capacity and resources to make that investment. So I just wanted to share that up front, that we are talking about access, but we don't fail to see that we are due for an upgrade and we need that investment. Otherwise, all this improvement to access really is not going to help us. All right, so next, talk a little bit about what is access, and what do you mean by that? And what do you mean by no wrong door? All right, so go to the next slide. So when I say access system or say access functions or no wrong door, what you see on the screen, this is what I mean. These are the various components. And so this might be a little bit more broader than you've imagined before, but we're talking about outreach and awareness, talking about resource databases, information referral, eligibility and enrollment, one-on-one counseling. It could be peer counseling, benefit counseling, options counseling, and this idea of governance and administration. Now, for a state or an organization, bringing it home to you, these access functions, I mean, we know they provide an opportunity to be that first impression, right? This is the front door to the house, right? But they also provide an opportunity to attract additional funding. And that's where I'm going to focus most of my time today, is how do we do that? All right, if we go up, actually, okay, we're in the right spot. Good job. Keep the questions coming in. I love to see them. Hopefully we get time to kind of address those. All right, so if you go to the CMS website right now, or if you type in no wrong door and claiming, it'll take you to this page. And so this is direct guidance from CMS on no wrong door Medicaid administrative claiming. But as I like to call it, just among friends, and when I'm talking about this, I call it Kohl's Cash. And so if you've never been to a Kohl's shopping store, let me explain. Let's say you spend $100 at Kohl's. Well, they'll give you $20 of Kohl's Cash to spend. That's kind of nice because you're already there spending the money, right? And they match that 20%. Well, CMS has said for every $100 you spend on your no wrong door system, we'll give you $50 to spend at a later time. And you don't have to spend it within a week. I've never been able to spend my Kohl's Cash because they always pick like 4 days and the time of year I'm never able to go. So you get a lot of flexibility in terms of how you spend it. But it's important to note that for many of you, you're doing these activities right now, but you're not getting the Kohl's Cash. So some of you are, and I have some examples, but it's an opportunity to get more additional funding for things you're already doing right now. So the first question might be, is this a real thing? Is it currently occurring? So I wanted to show you real quick on the next slide. It is. This is a current status of states that are participating in no wrong door Medicaid administrative claiming. And so there's 25 states that are doing MAC funding right now, active, currently doing that. And there's 14 more states that are in the planning stages. And so if you're in one of these states that are colored, honestly, it makes it a little bit easier in terms of the lift and be able to participate. But even if you're not, we can still find a way to do it. But we're tracking nationally about $60 million a year of claiming each year. And we're not even getting full reporting yet. Our hope is to try to go to about $100 million per year. But I wanted to show you a couple examples of how does this really impact of organizations, small and local organizations that are serving people at TBI. So if we go to the next slide. So these are a sample of states where you have disability organizations directly benefiting from no wrong door claiming. Now, near the end, I have actually a slide on Nebraska, so we'll dive into that a little bit deeper so you can actually hear their experiences. But I wanted to try to clarify that Medicaid administrative claiming, remember, this is administrative claiming, not a match on services. It's not a one-time event. So once you get approved, it's not like you'll get this funding on an annual basis. It's not like a grant where when the grant runs out, you then have to reapply and you're going through that process and it's, competing against other states. Once you get locked in, it's fairly consistent from year to year if you do some of the things that they need you to do. Some of the people have said, what's the process? What does this look like? So we do have a slide in here just to talk about it briefly. And so these are the things that need to be set up to kind of for this to occur. You can't just put up a sign on your window and say, hey, I'm ready to do some claiming. It starts with CMS. And so we break it up into two parts. There's the central office within DC or Baltimore that's approving that. And then there's the regional offices that are approving it. And honestly, they're a little bit different. Each one has its own culture and stuff like that. But just know that there's a two-step process there. You have the state Medicaid agency. Then you have the operating agency. Many times it's the state unit on aging. And then you have the local agency. And so agreements are set up in this fashion. And this is also how the funding flows in terms of how it goes up to CMS and then how it comes back down to the local organization. A couple of things that you have to have in place to be able to make this work. One of them is you have to have an MOU between the Medicaid agency and the operating agency. Even if you have incredible strong leadership within your SUA or the operating agency, Medicaid agency holds the key. So they definitely have to be able to sign off on it. But if you are in a state that they're already claiming, that's half the battle. And it's really a much easier lift from there. It could be an MOU or an MOA. I've seen both. All right. So just to kind of recap, if your state or your organization is performing any of these functions that you see on the screen, and this may surprise you, regardless of the individual's Medicaid status, and we can talk about that in a little bit, because you can claim for individuals who may not be eligible for Medicaid because you don't know when you're working with them whether they're eligible for Medicaid or not. These are functions that you can get reimbursed for. So if you have any state or local dollars that are supporting these functions, you could be getting match up to 50%, 50%, 50. All right. So my favorite part, but maybe the hardest part, is then with everything you have going on, everything you're trying to balance, all those emails that are piling up as you're participating in this day that are waiting for you. Why should I take action on any of these? Why is this so important? So I want to talk a little bit about that as we kind of bring this home. All right. I started the presentation about how human services is due for a major remodel, and it requires major investment for it to flourish. And it wasn't kind of just it was playful, but it was not a flippant statement. This is a report from the National Imperative. It's Joining Forces to Strengthen Human Services report. It was commissioned about 2-3 years ago. But I just wanted you to look at some of these data points that kind of give a sense of the stress that many of our community-based organizations are under. You know data, you don't need stats, right? But just, we use some of these. And so first, 30% of community-based organizations have less than 30 days in cash reserve. You have nearly 50% that have a negative operating margin, right? And so finally, most of the organizations impact, those in mental health, those in government human services, it's right in what we're doing. And so the need to have to attract additional funds is imperative, right? And so just wanted to just showcases that we know it is strained as is. And so organizations that do get funding from ACL and others, we have to look for some additional funding streams. And so in response, if we go to the next slide, we feel one of the key strategies to drive new funding to human services is through a coordinated no wrong door system. We're seeing other federal agencies step up and invest and bring in additional dollars. Yeah, the acronyms are hard. I agree. It's like another language. This is a side note. I've been in meetings at ACL where people talk and I didn't even hear a vowel. And so I agree. Acronyms are hard. But just so you know, I call this the hurricane funding slide. And so it's basically just trying to show all these acronyms you have floating around no wrong door. These are organizations and efforts that are investing money into this system. And so I've talked about community care hubs, which is another way that's happening, but there's also the veteran directed care program which provides a self-direction model to help serve veterans. They are an extremely aggressive path and plan to expand this self-directed model across the country. It's an incredible opportunity to bring in TBI providers to help support either a hub or a local hub, or they actually have regional hubs and even super hubs. It's quite interesting. And so we're excited about that. It's over a 2-year period. But the other area is Medicaid administrative claiming. It is a reality for organizations that are serving people with TBI. And so I wanted to show a couple slides of a presentation from the Brain Injury Association of Nebraska, right? So their mission, very similar to yours, is creating a better future for all Nebraskans through brain injury prevention, education, support, and services. And so these are in their words, in terms of their slides. Some of their experiences: first, they don't bill Medicaid directly. They acknowledge they don't have to have a direct relationship with the Medicaid agency. You can have it with the operating agency, or you can have it with a local ADRC or a local AAA. And so you don't have to have it directly with the Medicaid agency. One of the things you do have to do, you don't have to write a grant, but they have this thing called time studies. And at first it takes a little bit to get used to, but basically you're tracking staff time so that you can verify and validate this is what we're doing to warrant the reimbursement of funding. And there are some excellent consultants out there. We have a number of tools on our website that and I have an email address where if you want to get engaged. But there are some consultants out there that, like HCBS Strategies, that have worked with local organizations to make this happen. Some of the things they said, that this is life-changing, that they call it a pot of gold, and I actually have some numbers for that. But like I mentioned too, when you do Kohl's cash, you have to only spend that money at Kohl's. But when you do the claiming, you can use it in other places. And they talked about staff training, strategic planning, upgrades to their database, to address rising transportation costs, marketing and outreach. And so you have a little bit more flexibility on how to use that funds when you get reimbursed. And we'll go to this slide. And so these are some of the results. Now, this is a small organization. They had 8 staff members. They are statewide. But some of the things they provide are information referral, options counseling, case management. During their first quarter of claiming, they identified state and local dollars. They had reimbursable costs of about $71,000. So they got reimbursed half of that, which was close to $26,000. So that was their first effort. And they were very happy with that. They thought they might get $500. They didn't know going into this. The most recent quarter that they reported, they had over $250,000 they were tracking, and they got reimbursed of $110,000 of reimbursement. And so they showed that over a 12-month period, they have drawn down over $300,000 through Medicaid reimbursement. And they said it's changed their organizations, has a significant impact in terms of their ability to reach more people, and also just expand their mission. And also kudos to the State Unit on Aging there in Nebraska for, working with the Medicaid agency and also just giving them flexibility. And so it's a great testimony, I believe, on how to make this work. It did take a little bit of work from them, but it honestly, it looks like it's really paying off. So the last slide in terms of like, am I ready or how do I get this going? One of the first things you want to do is first, is our state in this game or not, right? How, are they claiming, are they not? If they are, it's a little bit easier lift in terms of either working directly with your state operating agency or what are the local agencies that are involved in doing this? Because you could then develop a relationship with them. And so to make this done. If not, if you currently aren't claiming, it's going to take a little bit more state leadership to start that. Doesn't mean it can't be done. I've been at the state level before. I've seen community-based organizations drive priorities to the state to make them to move them forward. And so it doesn't mean that it can't be done. I don't know if somebody's dropped in the email here, but one of the things that I think would be valuable is to get onto our mailing list if you're not on it already, to everyone. And so that's going to give you an opportunity to participate and hear about other things that are coming up. So I wanted to put that in there. And I think that ends it. And I'm happy to address any questions, or I'll turn it back to our facilitator so some of our advocates and incredible leaders can share their experiences.
Perfect. That is such a treasure trove of information that the two of you have shared so far. We wanted to end today's session with some information from a very personal perspective from two of the individuals that are involved with, as Sean mentioned to you, ACL's Traumatic Brain Injury Advisory Leadership Group. So with us are Ann Zaccardi and Martin Kerrigan. Both are very solid advocates in their states, both do a lot of presenting and authoring, and both wanted to talk about this as two people who have sustained brain injuries some time ago, who are thinking through what kinds of challenges and impact that has on their lives today. So thank you for joining us. We appreciate it. So maybe we could just jump right into this first question, and which of you would like to go first? What kinds of challenges have you seen or are you experiencing now within your own life related to aging and brain injury? Anne, you want to jump in?
Sure, I can go first. I was 49 years old when I sustained my brain injury. So I wasn't really thinking much about aging at that point. I am now I'm 61, I'm going to be 62 in a couple of months. So, it's becoming more of an issue for me that I've been thinking about, and especially after watching my father die of a rare form of dementia called posterior cortical atrophy, I became very concerned about the relationship between brain injury and dementia, depression, all of those things. So, I have found that as I get older, especially after 60, when things start breaking down in our bodies, I always am asking myself, is this the brain injury or is this normal aging? And Dr. I'm sorry, I can't remember how to say her last name. Monique Monique Pepitas addressed that a little bit. So it's, there's always so many other things to be considered when we are aging. And I am lucky that I don't have any other any other diseases, but I do worry. I worry about my brain all the time. So I have become a little bit obsessive about neuroplasticity, lifelong learning. I got my first master's degree when I was 57 after my brain injury, and I started my second one when I turned 60, and I started taking violin lessons. So like all of these things I know are supposed to be good for our brains. And I think I also work out quite a bit. I work with a personal trainer because I think functional fitness is very important for us, especially those of us with brain injuries, since we know that most brain injuries are caused, most concussions are caused by falls. So, just maintaining balance and functional fitness, learning how to move our bodies the correct ways to minimize risk of injury as we age has become very important to me. And I've kind of stopped watching the news and reading the latest about all of this, because I kind of feel like if I just, if I eat right and I exercise and I move my body and I keep my brain active, then hopefully, I'm doing all the right things to stave this off. But I would love to, be in a position to help advocate for people who aren't as good at self-advocating as I have been. So yeah, that's my story.
Thank you, Anne. And that's a great segue, because I know Martin is going to want to touch on some of the things that you've referenced as his own personal experience. Martin?
Sure. Hi, everyone. Thank you for having me. So it was interesting. So, I present on a variety of topics, and this is one that just is personal to me. When I saw this, I reached out to Marie and I said, look, I don't know if this would be appropriate. I mean, my behavior still puts me at like about that of an adolescent boy, but, that's not brain injury related. That's just me being me and who I am. But, I'm middle-aged now, and I'm, this year was 25 years since my brain injury. And I started to, this is something that's been kind of on my radar screen for a while. And, a generation ago, we didn't survive. So there's a lot of stuff out there that we just don't know, and, I would be lying if I said it doesn't concern me. Now, part of it maybe is it me being a little bit hypochondriacal. That just made up a word. But how much of this stuff, like Ann said, is related to my brain injury, and how much of it is just normal aging? So I did take a couple of different notes to kind of address this first question. So I'd say the biggest thing is the concern and the fear about the unknown, right? It's what might happen. I know what the research says. That the individuals with brain injuries have a 10-year lower life expectancy than those without brain injuries. That there's an increased risk of developing dementia and other memory conditions. My memory is compromised, especially when it's impacted by fatigue. And as the father of 3 young children, it's always fatigued, right? So there's these things I think that all play into it, that the brain injury doesn't, it only adds to those complications. For me, it's not just the fatigue, and I wrote this down, it's brain injury fatigue. And what I mean by that is, sometimes, especially, like I said, 25 years, sometimes it gets old, right? Like sometimes I don't want to just be like, oh yeah, that damn brain injury. Like, and maybe that's all me playing to my head, but it gets tiring. And sometimes you're just like, screw this, right? And you don't want it to impact you as much. And, for lack of, not to sound all doom and gloom, because it's not, but I think sometimes that brain injury fatigue can also lead to some people sometimes just being like, well, why am I even going to bother? Like, I'm going to kind of give up here a little bit, right? Like, I'm going to give up on doing, the next healthy thing. Because, to be honest with you, like, I think eating salads every meal can be kind of boring, those are the things that kind of cross my radar screen. And then, there's the physical consequences. So there's the physical consequences that can be related to the injury. So most of us had were involved in an accident or something that led to our brain injuries. And there's physical consequences to that as well, and as Ann talked about, we have, lower rates of coordination, increased risk of falls. I'm a runner. I've always been a runner. I'll always be, I took on my run on Monday, I fell 3 times, right? Like now I was running on trails. I was tired and I was due for one because I know, about once every 6 months, I'm going to take a good spill. Right. So I was like, okay, hopefully this took care of for the next, maybe till the end of the summer. And those are the kinds of things that where, I'd be lying if I didn't say every single time something like that happened, first thing that went through my mind wasn't the damn brain injury. Now, would that fall have happened if I had a brain injury? Who knows? There's roots, there's, rocks, I'm clumsy. But again, those are the kinds of things that happen. So, that's what it is. And I'll stop with this. It's the whole idea of, that question that Ann said, is this just normal part of aging, or is this the brain injury? And then there's also the increased risk of, well, are these things going to increase the risk of a subsequent brain injury, which also scares me. I mean, it does. I've been through it once, don't want to go through it again.
Definitely. And it's hard to separate out a lot of the things that you're talking about. But, those are things that all of us experience and all of us worry about, and as someone who is aging like the rest of us are, you do stop and ask yourself, is this a part of aging? Is it part of something else? What are the genetics here? And you mentioned a family member, those kinds of things do cross your mind. I'm thinking about what Monique shared with the care model, and we know that another continuum of care model is being developed. Are there some kinds of services and supports that individuals who are aging with brain injury need to have? Are there things that come to mind that you think need to be added into this sort of holistic mapping?
I'm still thinking about this question, so I'm going to defer to others on this one. I don't know the answer right off the top of my head.
I jotted down some notes because Maria was kind enough to share some of these questions with me beforehand. So the first thing that comes to mind to me is, very simply, it's the same as anybody else aging, just through a brain injury informed lens. Really, just looking at it through, I know I use that word a lot, or that phrase a lot when conducting trainings and best practice and everything. It's, we're not asking anybody to reinvent the wheel. We're just asking you to approach it through a brain injury informed lens. And to add on to that, it's, like I said, fighting that brain injury fatigue, right? Like that, just gosh, and when I say brain injury fatigue, I don't mean the literal. It's just, it's always there. It's always present. How do I, get past this? Because again, I like to say all the time, we're more than our brain injuries, right?
Right.
I am not a brain injured person. I'm a person with a brain injury. And then there's a couple other things that I jotted down. So I think one of the big things is what we as a system do is we need to do more training and professional development for providers. And I am not talking brain injury providers. I'm talking about medical. I am talking about, the Department of Aging. I mean, it's already there. It's only going to grow. Our population ages, the aging, it's a growing thing. So, you got to get on board sooner or later. And I really feel that is very, very important. And that to me would be one of the top things that we could do is to get advocate for that is, hey, where is that brain injury, and whether it's part of, certification, ups, social work training. I don't know that world all that well. But I think that really is important. I also think too, support networks for people living with brain injury. So support groups, especially as you age, right? I can't speak enough to the benefits of support groups. And I think, there's different support groups for people. And I think just having one giant support group might not always be the best. But if, there's different support networks, especially in the world of virtual now, it's a lot more feasible than it used to be to have, aging or, 25 years plus, something like that. I find that that's really helpful to people. Practically speaking, I think nutrition, sleep habits, screen time, etc. All those things that, we know is good for everybody. It's also good for people with brain injuries, probably just more so.
Right.
And then, one other thing, and again, those informed providers is good. And then I think, the last note that I have that I took down for this question right now, besides the brain injury informed language, I can't emphasize enough. You got to become your own biggest advocate, right? Like, you better than anybody else, and don't be afraid, and sometimes you may have to be the one educating the people working with you about brain injury and what it looks like for you, right? Because we know that saying, you've seen one brain injury, you've seen one brain injury.
Right.
So, it's advocating, this is what I need, right? And this is what it's all about, right? This is person-centered practices. This is patient-focused, this is, you're the driver of your own, treatment. It should be the same thing in this world, because sooner or later, I hope I look to the point where I'm going to need somebody else to advocate for me, right? And that's the goal. And I'd rather it be somebody who gets brain injury and who knows it, as opposed to somebody just looking at me and saying, "Oh, we're making a judgment based off of 5-minute observation without having all the facts."
Right. Thank you so much. I appreciate your insight. If Terry, if we could pin Joseph and Monique. We have just a few minutes for questions, and we don't have a break between this session and the next. So I want to be respectful of our next set of presenters' time. But if we have a minute, I know there are just a few questions that were put in the chat, and thank you guys for asking as many questions as you do. It's good to see where your areas of interest and passion lie. Just in taking a quick look, Joseph, I appreciate you referencing Nebraska's Brain Injury Alliance. That's work we're very familiar with, and we're going to highlight that in the summer with some training opportunities that are coming up. I saw something, Monique, I think this one is for you. Anything more you can talk about with female patients and lower rates of readmission? Is that due to caregiver roles or some other factor?
Yeah, so based off of the results, so that's in comparison to males. So males are at increased risk of readmission compared to females, and so thinking about it vice versa. Yeah, I also think that's the case. I mean, I honestly think that another part of this work is actually talking with individuals about their experiences and with readmission and the supports that they received to that or didn't have or what was going on that caused them to be readmitted. But yeah, I mean, I think overall and just in the general population, looking at that kind of relationship between the sex difference with regards to readmission, yes, it's often females playing that kind of supportive, caregiver role, and then often in the literature related to kind of self-management and actively engaging in oneself in health, you see some differences there where females are a bit more engaged with interfacing with healthcare providers and seeking care. And so that could be playing a role in it too. And there may be other factors that are, not measured that could be playing a role. It's in an individual's case. It could be that, though it just so happened that the men in the group had more, challenging, serious chronic conditions, right, that place them at greater risk for having to be rehospitalized. So a lot of different things could be at play, but I'm the one, it's great. I love data, but I also love to hear people's story and their experience and to better understand exactly, get a picture of what's going on, where's the breakdown, how can we better support you?
Gotcha. Thank you. Speaking of differences, I also saw something in our chat about adherence differences between older adults with brain injury and younger adults with brain injury. Any self-management tools that any of you know of that might work well? As Martin and Ann talked a little bit about being a better self-advocate, I'm wondering if there are some management tools available.
I mean, so there's, I can't specifically recommend like, oh, use this one, right? But there are a variety of just with technology. I know a lot of people always say, oh, older adults aren't into technology. I'm sorry, that's not true. And so, there's been a lot of work in using phones and technology to better help individuals, those reminders. I mean, I even use them to help remind me, okay, it's time for me to make this, appointment, or taking this medication, or whatever it is that you're supposed to do to help manage your health. And so I love them. A lot of older adults that with whom I've communicated love those tools because it kind of helps them, the reminder features of it and the documentation, and to be able to see trajectories of, like, my father loves that I gave him something to help him with tracking his blood pressure, right? And so he could see how, over time and during days, and he also includes context, right? To say, okay, this is why my blood pressure was increasing, and but generally it's the same. And that's great things to take to your provider as well, and to help support those conversations with your provider.
Right. Joseph, this question I think is addressed to you, and I think it'll be our last as we are at time, but I saw that someone put in the chat if Medicaid administrative claiming was available for reentry services with states under 1115. Any insight you can share there?
You could probably get it. I don't know if it would be considered match, Medicaid administrative match. We've seen care transitions used for administrative match, but I don't know about that. So I'd have to check. The other question I also saw was about, is there a deadline to use the funds? And so from our perspective, we haven't come across that yet. So it could even go beyond 12 months. But we haven't seen it yet where that has been an inhibitor of people not being able to spend their funds.
Thank you. Thank you for that. And thank you, all of you. This was outstanding. I think we could spend about 2 more hours talking about aging with brain injury for sure. We appreciate your time. And Terry, turning back to you.
Hi, everyone. I'm Rebecca Wolfkiel. I'm the Executive Director of the National Association of State Head Injury Administrators, NASHA, and I'm delighted to round out the day with you, facilitating a session on multi-occurring conditions. As you know, in the brain injury community, we are no stranger to multiple health concerns and juggling all of the co-occurring challenges. And today I am excited to be able to talk about a new initiative that is really focused on building systems that support people with various cognitive disabilities, including brain injury and intellectual and developmental disabilities, as well as mental health challenges. So just sort of at the outset, as a reminder, we know that anywhere from 60 to 80% of people living with brain injury are also living with co-occurring mental health challenges. We also know that anywhere from 30 to 60% of people living with intellectual and developmental disabilities are living with mental health challenges. And we know that people with IDD are also much more likely to have sustained a brain injury than the general public. So there are a lot of intersections here, but unfortunately our systems just aren't quite ready to support people with these very complex conditions. And so I think at the very outset of the day, Allison Barkoff mentioned some exciting new initiatives, and I'm delighted to be able to expand on some of that today. ACL has funded a new technical assistance center called the Link Center. And the panelists that I'm presenting with today are all involved in this Link Center in various ways. So I would like to welcome my co-panelists to come on camera, please, and we'll have a discussion and talk about the variety of ways we're all engaged in this exciting new resource. Okay, I see Mary and I see Eric, and there's Stephanie. Wonderful. Well, welcome everyone. Eric, I'm going to start with you. And Eric Washington is someone that I'm going to guess most of you are familiar with. He's one of our community's a wonderful advocate that has been engaged in a variety of issues. And so, Eric, I know many people have heard your story, but for those who have not yet, could you please introduce yourself and share your personal story?
She always gives me just a great welcome. I appreciate it. So my name is Eric Washington. I'm from Detroit, Michigan. Played football since, I'll give you the short version. Played football since maybe 6 years old. Suffered multiple concussions just based off of just how football was taught back when I was growing up. You know, our coach would always say, hit the man in the head and the body will follow. So everyone was just ramming heads and doing backflips off of mattresses in the alley, all types of just cool, fun kid stuff. And then I'll fast forward to the now. I'll fast forward to when everything kind of happened. Played football for the University of Minnesota first. I started having concussions real close together. And, you know, it started to like alter my attitude, alter my mind state. You know, I couldn't really read. My eyes had issues tracking and tracing. I couldn't focus on anything, so I thought everything was boring. And I just had just temper issues. You know, a lot of times people think that because a person is acting out that, you know, they're just not getting their way or, you know, they're just upset, but that really wasn't the case. I was just very reactive for some reason. Then I got to the University of Kansas, and then I actually broke my neck on television against the University of Nebraska. And then I also had a concussion at the same time. So what ended up happening was instead of them dealing with the brain injury aspect of it, they decided to deal with the spinal cord injury, which obviously was just the #1 priority. So the brain injury took a back seat, everything else kind of, you know, let's get them back walking, let's get them back breathing, all of those good things. So then years later, I decided to go back to class and I just continued to get straight F's, you know. And then eventually the school just let me pass. So then I finally went to an eye doctor and he started to notice that my eyes had issues for some reason, tracking and tracing. You're supposed to read from left to right. My eyes would just jump. So if I didn't remember what I saw, I couldn't really, you know, spit it back out. And then eventually I tried to get a job, got fired, got a second job, got fired. Then I ended up homeless. So, you know, after being homeless for 3 years, I couldn't figure out what the heck was going on. I couldn't really figure out why I was in that predicament. And then I would get in trouble a lot at bars. And then the police officers would see me and they would say, hey, we know what's wrong with you. We just really need you to go get some help. But then you don't really know what help is, you know. 6'3", 235-pound African-American male, they look at me as I'm lazy, I'm a girl, you know, I'm not tough. So therefore, you know, it's just frowned upon in general. So eventually I tried to, hurt myself. Then they found me in the ER and they said, look, you're gonna go to jail or you're gonna go to, mental health counseling. You're gonna get locked up in this mental institute or you're going to jail. So I decided the latter, to go to the place where I was playing basketball on carpet with no shoes on, which I thought was crazy. It made me crazier. Then eventually they found out that, I just was grieving. I was a person that had lost everything. I had a brain injury. I had just lost something that I've worked for my entire life. So eventually I sought out some help from the Brain Injury Association in Missouri. They kind of got me back on the horse. I got a place to stay and kind of like stabilized my life. So that's kind of the spill of, what I went through in the beginning.
Oh, thank you. You are such a compelling advocate, and we appreciate you being here to share your story and to really, you're the face of why what we're going to be talking about today is so important. And it really illustrates the needs for the system integration so that people, when you're receiving care and people are receiving care, they're thinking about your brain injury and your behavioral health concerns and, your physical challenges and not just focusing on one thing at a time. So thank you so much for sharing that. Next, I'm going to turn it to Stephanie O'Day, who's the Director of Maryland's Office of Older Adults and Long-Term Services and Supports within the Behavioral Health Administration. Stephanie manages the brain injury program as well as part of her work. And Stephanie, Eric's story is not unique. And I know in your role, you support people like Eric every day. And so I was hoping you could take a few moments to speak about the challenges from a state systems policy, level of supporting people with these multiple occurring needs.
Yeah, sure. Thanks, Becky. Appreciate being here today. So I think, hi, Eric, by the way. Thank you very much for sharing your story today. I think that your story really points out how the continuum of care could just break down at certain points. I think states in general create programs for specific conditions or disabilities, but as you point out, people can have more than one condition or disability or medical condition, and that can just lead to a situation where only some of your needs are met and not others, or none of them are met. And what I've seen is people with co-occurring conditions can at times just end up being denied from all the programs, because in the 23 years I've worked here, and I think that there has been some improvement on this, but one of the most common things I've heard since I walked in the door when I'm collaborating with my colleagues around trying to figure out, how to help a particular person, people will ask, what's primary? Words that I have grown to absolutely hate. And even though I think they're used with the best of intention, we've built these programs, they're for specific things. So what's his primary problem? And then we'll figure out what he's eligible for. But, that obviously doesn't take into consideration the whole person. And I'm not going to speak for Eric, but I'm just going to take a guess that what Eric might have considered to be primary may not have been what I, as a state person, might have identified for him as his primary issue. And probably more importantly, it's also connected that everything is primary. And so that logic doesn't make sense, but that's logic that I've seen applied so many times, just because the way we develop these systems is always, we've got something for people with intellectual disabilities, we've got something for people with brain injury, we've got something with people with mental illness, we've got something for substance use disorder. So what's your primary thing? And that's where we'll send you. And that just doesn't work. Eric, if I am misrepresenting you in any way, I want you to know you can feel free to chime in.
Oh, no. I think that's 100% correct. So I left out a very important piece about the co-occurring issue. So I started drinking. Everyone that knows me, I'm a very extremely open person. I'm just an open book. I started drinking literally when I was 8 years old. Hardcore liquor. That was how you got over people that died. So drinking that entire time, once I had my brain injury, once I had lost my career, that's where the co-occurring thing started, where it was, I drank because I was mad, and I was mad because I was drinking. So I was going through this circle of just chaos, and I couldn't really get out of it. But then when I went to seek help, it was always thrown back in my face. I did a I forget what it's called, psychoneural exam or whatever, where you take these tests. And I failed the test. It's not a pass fail, but it wasn't a high. And what ended up happening was the doctor said, well, I just think you're drunk. So I just started crying. I got mad. I started tearing up everything. And it was like, he's like, there's no way a person with a degree cannot remember what he did yesterday. And I'm like, but where you get injured playing football, it makes perfect sense. So therefore, it was, even when I reached out for help, the answer was always where you drink or you've drank, and that's not always the case. The first issue is, one, we had to get me off the streets. If I'm homeless, I can't think straight anyway. So then it was like layers of onions. We had to get to the bottom of it. So once the alcohol was removed, I said, sir, I haven't drank in 3 years. So there's no alcohol. I have no place to stay. There's something else wrong, which was I was depressed because I couldn't get out of this rut, but I didn't know how I got here. So that's kind of what happened.
Well, you would think that we rehearsed this together. I'm so sorry to hear that that was your experience. It pretty much reinforces my next point, which is this phenomenon we call the invisible injury, where the history of brain injury may not even be recognized to begin with. So I think most people in this audience are probably very used to that term, but we can use it in a number of different ways. So sometimes we say invisible injury because the person with the brain injury might have more, resulting issues that are more cognitive or emotional or just not apparent to the observer. So if you're looking at Eric, you may not notice that he has any problems because it's not physical. It's in his head and it's not obvious. We call that, the invisible injury. But it's also called the invisible injury because so many times people who sustain that injury don't actually trace the issues that they're having back to the injury they had. And similar to what Eric just shared earlier about when he did have his major injury in college, he also had a spinal cord injury. So, that happens so many times. People have an injury, have an accident, a crash or something where they've got, major organ damage or they have a spinal cord injury. They have these things. There's a hierarchy, there's a triage system, and that injury to the brain may either not have been detected, might have thought to be mild, isn't really the priority of that hospital admission. And so the person leaves kind of not even really realizing they've had that brain injury. And so years later, they're struggling and they don't necessarily trace it back to that injury. So again, I don't think that's something that we're not aware. In the brain injury world, we know this, but in the behavioral health system and crisis services and pretty much anyone that's not in the brain injury world, they don't know this. And so if it isn't obvious to them, that poses a challenge. I'll stop there, Becky, because I know you have other questions for Eric or me or somebody.
Yes, no, thank you. That was perfect and a great way to kind of lay the groundwork. So I think I'll now turn it over to my colleague, Mary Sowers, who's the Executive Director of the National Association of State Directors of Developmental Disability Services, NASDs. And Mary's team at NASDs has been right in the middle of developing this new Link Center. So Mary, I know you brought some slides along to share with us, and I'd love to turn it over to you to give us a bit of an overview about the work that you are leading.
Thank you so much, Becky, and thank you, Stephanie and Eric, for really laying such a terrific foundation, because what you described, I think, is exactly the reason that the Link Center was created to begin with. So we are especially grateful for, one, Eric, you sharing your very personal stories, because truthfully, we can't change policy without really understanding the impacts that policies are having on people's day-to-day lives. And Stephanie, I know from the state policy perspective that you're in the midst of juggling both sort of federal expectations and different constraints within the systems that have built up over time. So I'm really thrilled to be able to talk about the Link Center. And is there someone to advance the slide? Perfect. Thank you. And the Link Center is still fairly new. It was funded in September of 2022 by the Administration for Community Living. And I just want to pause and take a moment to thank ACL for their visionary leadership on these issues. I think when I get into describing what the goals of the Link Center are, you'll see how needed it is, and probably will say, wow, you know, we could have used this for many years. So we're really thrilled to be able to be a part of this exciting initiative, and are so excited at the national landscape and the partnerships that are emerging with ACL and SAMHSA and other federal partners, which I'll also talk about a bit. Next slide, please. So the Link Center is a project of national significance funded by ACL, and it's really born out of what you've just heard, that our country struggles to provide community mental health services for individuals with intellectual and developmental disabilities, brain injury, or other cognitive disabilities. And there's a lot of reasons behind that. We'll talk a little bit about that. But we also know that individuals who have significant support needs or complex support needs or have multiple system support needs really stretch our state system's ability to provide services and supports in a person-centered way. And so we know states are really wrestling with the best practices on how best to address these issues, especially thinking about the silos that Stephanie really so eloquently laid out, you know, on how all these different systems have grown up independently of one another. We know that states are experiencing pressure from the legal system to make improvements in this space. And so we know there's an urgency to address these issues, but we also know that there's a lack of expertise. There are resource and capacity challenges to support people with co-occurring or multiply occurring diagnoses with brain injury and IDD and other disabilities and mental health and substance use issues. And there's, again, a lot of origin story behind that. And then we know that in addition to sort of the silos and the systems having an inability to be as flexible to wrap around someone as they need to be, we also know that the clinical professionals and law enforcement and the crisis care providers don't necessarily have the tools in their toolbox to effectively interact with folks. And sometimes that can have really terrible outcomes. I think you just heard a really good example of that from Eric's example. Next slide, please. So we're really thrilled, and it's hard to contain myself a bit on how historic I think this partnership is. We are so grateful to Becky and the team at NASHA for joining us in the Link Center. We also have key partners with the National Association of State Mental Health Program Directors and NAD, and our four organizations really take the lion's share of the leadership with the Link Center. That said, we couldn't do it without our other key partners. So as you see through this list here, we've got partners representing individuals with lived experiences through Green Mountain Self-Advocates, the Autistic Self-Advocacy Network, and Communication First. And then we've also got university partners to help us understand whether what we're doing is making a difference. But some of these university partners also have great outreach and connections with underserved communities or marginalized communities. And so we want to make sure that all the work of the Link Center has the real all in mind as we're thinking about how do we, you know, improve access to mental health supports and services for individuals with co-occurring or multiply occurring disabilities. Next slide. So this was the spark for the original partnership with NASDS, NASHBID, and NAD. And then more recently, I think the same origin story can be told with NASHA. That while the associations have recognized the importance of working together, there hadn't been opportunities. So SAMHSA, the Substance Abuse Mental Health Services Administration, had convened a roundtable in 2018 around the issue of people with IDD and mental health conditions. And from that meeting, it just sparked an ongoing partnership across our associations long before the Link Center was really a glimmer in the eye of our federal partners. But we've had the opportunity to build some work together across our three associations. And I think quickly realized that we were missing an important component with brain injury in that mix. And so as we move forward, the commitment of all of our organizations is to be in lockstep, because as Becky laid out, there's a complete overlap of both the people we serve and the experiences of care for individuals with brain injury and intellectual and developmental disabilities or other cognitive disabilities, or people who, with different communication styles or modalities. And so we just want to make sure that as we're thinking about the solutions, that we're really thinking broadly about the universe of people that can benefit from them. Next slide. So the key goals of the Link Center are really threefold. We really hope to spark some systems change. You just heard in way more eloquent terms from Stephanie and Eric about the real impact when systems don't work for people and how it creates really big holes for people to fall into when we aren't creating a person-centered approach. So our hope with the Link Center is to identify areas where we can make improvements in federal policies or in state practices, in service designs or in service accommodations, and how services are coordinated across different agencies, and to spark some systems change across those elements. So that's a lofty goal by itself, but we know some of the areas that require improvement now, and almost on a daily basis, we're finding more, sort of where we might have policies or practices that sort of take away from the opportunity to support people in a holistic, person-centered way. We know that we've got a national crisis on the direct support workforce, and also in the clinical workforce arena, a dearth of clinical professionals too. And this is exponentially more true for individuals who have cognitive disabilities and co-occurring mental health conditions. So we know that we've got to do a lot of work to make sure that the direct support workforce and the clinical workforce are supported and have the tools in their toolbox necessary to support people who present and might communicate differently, or who might need more additional time to be able to build relationships for clinical mental health treatment. We want to make sure that we have an eye toward both giving them the tools to be able to perform supports and services to help individuals have good lives, but also to make sure that the systems are supporting those investments that are necessary. And the one thing I'll say, I'll talk a little bit more about this in a moment. We know that there's been a huge challenge because of that issue that Stephanie raised of primary diagnosis for individuals with IBD or brain injury from getting access to mental health treatment. Because of the way our systems are set up, sometimes if individuals present, there's a presumption that an individual can't be experiencing a mental health crisis because they have an intellectual disability or because they have a brain injury. And those misconceptions have really led to bad outcomes for people. And so we're really hoping that as we build out the tools for the workforce, that we can chip away at some of those misperceptions that unfortunately still exist among some of our professional colleagues across the country. And then most importantly, or as importantly, we are hoping to expand service access. We know that we've got a lot of work to do to improve person-centered, culturally and linguistically appropriate mental health services and community supports for people with disabilities. And so really making sure that we've got our eye toward really opening more doors for those necessary supports and services. Next slide. So at the Link Center, we've got sort of on the left side of the slide, you'll see a focus area of diversity, equity, and inclusion and continuous quality improvement. And in my mind's eye, those are sort of the rudders by which we do business. We want to make sure that whatever we are doing in the work of the Link Center, we've got an eye toward making sure it's inclusive. And that means across disability, race, ethnicity, sexual and gender orientation, communication modalities and styles and preferences, and really thinking through very globally about how we can make things universally accessible to people. But we also want to make sure that we're building in opportunities to learn and to as we're going forward and trying things or sharing information, that we have got a feedback loop to understand whether or not we have the right tools that we're putting forward, or if we need to change how we're thinking about something. So very much looking through this process as a continuous learning opportunity. As we, one of the things that's, I think the most important work of the Link Center is really the steering committee. And we are extraordinarily thrilled to have welcomed our newest member of the steering committee last week, Eric Washington, to the Link Center steering committee. But the steering committee is made up of individuals, exclusively made up of individuals who have lived experiences. And so that group has really identified and surfaced issues in a way that is so powerful, and it's driven really the work of the Link Center since its inception. So we are really thrilled that we've got such a group of esteemed partners in the steering committee to help us shape the work of the Link Center. And in a very practical way, where, they're obviously, because of their lived experiences, they are bringing to bear some really tangible examples of where the systems have worked, and probably more often how they have not worked, and things that might make things better. And so we're really trying to incorporate all of that information that they're sharing with us into both the shared learning groups that you'll see, I'll talk about in a moment, and the resource development. But the other big piece of the work is a shared learning groups approach. So quarterly, the Link Center hosts 4 meetings, and they all cover the same topic, but they're geared toward different audiences with some slight modifications to make them applicable. So for example, one of our first shared learning group series was on crisis and how to support people who might be in crisis. And we have a meeting tailored for individuals with lived experience, for families, for direct support professionals, and for clinical professionals. And the bones of those learning groups are the same across the audiences, but we really tailor the information in a way so that those individuals attending can use it in their day-to-day life or in their day-to-day work. And so we want to make sure that we're reaching that effort has also spawned the identification of gaps where we need things developed, and the Link Center is really trying to fill in those gaps as we identify them. We will have a website very soon, and that will host a library of tremendous resources that we hope to grow over time. And so a shameless plug is if you have any resources that you have found to be especially helpful in thinking about mental health co-occurring with disability, we are always taking those in, and our partners at NASHA can be a conduit for that information as they're sharing those pieces too. Next slide, please. So this is just sort of a different view of what we're really hoping on the output side of things. We'll have a library, there'll be a TA hub where on the website where you can request TA or get information on different pieces. We really want to identify best practices and to help scale those across the country, and think about different ways of training both clinical and direct support professionals, and elevating those things that are working well across the country. So next slide, please. So as I mentioned on the steering committee, this is a tidbit that we always love to share. When we recruited for the steering committee membership, we had an overwhelming response. So we invited individuals who self-identified as having a developmental disability, a brain injury, other cognitive disability, and mental health condition to apply. We had more than 100 applications of individuals with lived experiences who wanted to serve on the committee. And the committee is only at this point 13 people large. We wanted to make sure that people had opportunities to talk with one another and get to know. But what was so really, I think, encouraging about it is that it was people from all walks of life, from across the country, from rural areas, from urban areas, with different cultures and ethnicities and age, disabilities, communication styles. And so we know that we found this to just reaffirm that the work of the Link Center has never been more important, and it's really so necessary across to really begin to tackle these issues. So we're really excited about the steering committee helping us in this work. And I should also say, and Eric heard this last week at our last meeting, the steering committee members help, advise the work of the group, but we also tap them to help us with the shared learning group development or tool development so that their lived experiences can really infuse the work that we're doing elsewhere. And that has been just a tremendous asset to the center. Next slide, please. So we are extraordinarily thrilled. And again, folks that have heard me speak about the Link Center before are probably tired of hearing me say it's pretty historic, but I've been around the federal government for a very long time, and never have I seen the partnerships across federal agencies happening in the way that I see them happening today. And so a really good example of this is the partnership with SAMHSA. Next slide. The leadership at the Administration for Community Living and the leadership at SAMHSA have come together to fund the Link Center's activities to develop a policy academy for states to really ensure that the 988 and Suicide Crisis Lifeline are accessible to individuals with disabilities. And so we're really thrilled. You can go to the next slide too. We're really thrilled to say that we have selected 6 states. Again, we had an overwhelming, really positive response from states wanting to participate, including the great state of Maryland, which happens to be my home state, not that I'm biased, but we have Maryland, Virginia, West Virginia, Georgia, Ohio, and Kansas have joined the Policy Academy. So we're extraordinarily thrilled. And what the Policy Academy aims to do is bring teams together from the states. The teams have to consist of 988 and Crisis Lifeline, agency staff, Medicaid, mental health, developmental disabilities, importantly, brain injury, and child welfare. And then the states can also round out their teams with other partners as they see fit. And many have included their University Centers for Excellence or their Developmental Disabilities Council to make sure that the TBI partners are helping shape that work too. And the real hope is to help not set an expectation that every 988 worker is going to be completely conversant in all aspects of disability, but instead they'll know where to go for the supports so that individuals can experience the crisis stabilization that anyone who might be experiencing a crisis will need in the emergent time, but that there are relationships established within the state so that ongoing supports and services and really disability informed approach and trauma informed approach can infuse that work. So we're thrilled. We're just getting started now. So hopefully I'll be able to come back in a year with some of our partner states and talk about the successes in terms of building those cross-agency structures and collaboration and partnerships that unfortunately are not well established in a lot of states. So we're really hoping to work to build those and to make them really lasting as the 988 crisis lifeline work continues in states. Next slide, please. So we've got, I think, again, challenges and opportunities and next steps. You can go on to the next slide. It's really an exciting time. We've got an ongoing effort. I think we see as part of our core vision is to sort of debunk these myths that people with IBD or people with brain injury are one-dimensional, that indeed that they can only experience one thing at a time. We've got to sort of remove the myth because our service systems reinforce it that individuals with disabilities don't experience life in the holistic way that the rest of us do. And we just have to combat that bias. And so that's one of the pieces that we feel is very key to us making systems change and to really changing perceptions about individuals' ability to benefit from mental health treatment. But we also know that we've got to improve our cross-system partnerships. No one system can support someone by themselves. And so we've got to think about ways that can overcome some of those stovepipes that have really wound up being a disservice to people with disabilities across the lifespan. But we know all of these things are contingent on a strong, well-qualified, and well-supported workforce. And so as daunting as that sounds, because we are all experiencing, I think, workforce issues across the country, we know that it is essential to chip away at the availability of making sure that we've got access. And the other piece that really looms across all of these is making sure that we've got an equitable and accessible service delivery system. We know in many of our systems that we aren't serving the total number of individuals who could benefit from those services. And whether those are resource limitations or because we've made the access points so complicated that marginalized communities or individuals who might not have strong support systems aren't able to access them. And we've got to do a lot more in that regard to break down some of those barriers. Next slide. So this just in closing, I'm super honored, very grateful for the work that NASHIA does with the Link Center and just how much expertise they brought to bear, and extraordinarily grateful to Eric for joining the steering committee to help shepherd the work further, and very much looking forward to diving into the Policy Academy with Stephanie. So thank you for this opportunity, Becky.
No, thank you, Mary. I hope that everyone can see just truly the energy that Mary and her team have brought to this approach. It has been really a breath of fresh air. And I think at the community level, I know for the brain injury community, I can speak to a bit that we're always trying to ensure that we're part of some of these discussions. And I really feel that because of Mary's leadership and ACL's leadership, this holistic approach that Mary just described has already been trickling down to the state and I believe soon the community levels, because it really is just such an impressive, it's such an impressive and contagious effort, and the enthusiasm from the community has really been wonderful. So as you can tell, it's still in sort of the infancy stages, but it's going to be so exciting to see over the next couple of years all of the work and activity that comes from it. So I did see one question in the chat that I think, Eric, I'm going to turn it back over to you for a moment, because you are a participating member of the steering committee, and I know that you just started that work, of course, but I also know that you are asked regularly to be involved with efforts like these, and you only have so much time to be able to dedicate. And so I guess if you could speak to why you felt that this was an effort that was worth you really putting in the time and your contributions, I think, that would be, and I think, sorry, too, the question in the chat was really around making sure that voices of people with lived experience are really taken into consideration and used for implementation. And so if you could kind of speak to your experience so far with the group and why you felt like it was worth your precious time.
Can you hear me?
Yes, we can.
Okay. So I'll start off with, there's two sides to a coin. So you have to have empathy on both sides. I decided a long time ago, I wanted to be a part of the solution instead of the problem. I have some people are just naturally charismatic. I can start talking and people start standing on tables. So if I really got upset at Mary, we could shut this thing down, but why not just help? And I think what happens is that the brain injury community, which I'm a part of, we want results right now. Get it done. You've been talking about this for 7 years. You haven't done anything. Then you have the other side of the coin, the Marys, the Stephanies, where they're like, we're trying. But see, both entities have to understand and have empathy for one another and work together. And that's naturally a part of the problem. I think a lot of people, we're so busy pulling apart where we're talking about diversity, equity, inclusion. Really, there should be inclusion for everyone. It's not just Black people. I think a lot of people just mistake that for, when there was a lot of racial things going on in the world, they think they just created that little bracket for just minorities. No, brain injury is a minority within a minority. It's one of the smallest, poorest, disabilities you can have or cognitive issues. So therefore, there's not a lot of understanding. There's not a lot of research. A lot of times you have to, be dead to even know if you have CTE. You can't do a test while he's alive. So you don't even know what the person's dealing with or not dealing with. I have cancer, so I also do chemotherapy. So there's something called chemo brain that rots your brain on top of something that already rotted my brain. But if you don't understand or take the time to, see it from my standpoint, then it's only one-sided. I, a lot of times, have issues with things moving slow. But since I'm on the other side, I see why it moves slow. Without people in the chat that have lived experience, being able to learn how to tell their story without being upset, those are the things that pass law. You can't pass a law if all of us stand on the table and tell them that they're wrong. Then they're going to say, okay, so what should we do about it? And you're like, I don't know, do something. That's not productive. That's not going in the right direction. So I try to help people learn how to tell their story in a way to where they're not upset anymore. They're kind of past it and they want to be more productive. And those stories, when it comes to Heal Day, and you sit in front of your legislator, I can assure you that when you say your story, he's going to care more about your story than those statistics that any person put on the table. Because at the end of the day, you could be his daughter, you could be his son, you may be his wife or his husband. So they're going to relate to those things. They need us the same way we need them. But if we're not available to them and they're not available to listen, this isn't going to work.
Such a great point, Eric. I could listen to you all day. You're just so empowering. One of the things you mentioned earlier, Eric, was experience in crisis. And I heard Mary talk about the importance of a focus on 988 crisis support, and particularly with people that have a number of multi-occurring conditions. Stephanie, your state of Maryland was selected, congratulations, to be part of the 988 Policy Academy. And I know that is in the very infancy stages. States were just alerted just a couple of weeks ago. But from my perspective and what I've seen so far, it seems like a very collaborative process, just sort of engaging with the center. So I was wondering if you could talk about your experience so far, what the application process was like, you know, what it's like on the ground, if you feel like this, you know, comprehensive systemic approach is really trickling down to the state so far.
Yeah, absolutely. Well, for Maryland, I guess this really came at a perfect time because our governor and our Department of Health had just launched this major effort to build the statewide continuum. And so the timing was right. The application process was extremely collaborative. In our state, our Developmental Disabilities Administration took the lead on gathering the group to work together on this application. And we have basically had they pulled in representation from behavioral health. And in Maryland, behavioral health is the lead agency on brain injury, but I'll get to that in a second. Department of Disabilities, our Medicaid agency, our Department of Human Services, which is, you know, child welfare and other things, our Center for Excellence in Developmental Disabilities. And they specifically asked for my colleague, Anastasia Edmondson, and I to participate in this process right off the bat. And I just want to say how grateful I am that it was a requirement in this application to bring in the brain injury lead agency or subject matter experts, because even though our lead agency is behavioral health, you know how these things work. There's a very short turnaround. It was a very short document that you were going to submit for your proposal. So it would have been easy to miss it because there was just so many other things to put in there related to intellectual disability and behavioral health and our crisis system and where we are in Maryland. But we got invited right off the bat to submit, you know, our CVs and to help with editing and creating the application. So I thought that was wonderful. We were able to garner a letter of support from the Brain Injury Association of Maryland, which they did willingly. And, you know, I just think that that was great. The other thing that was interesting that I realized when we came together for our first meeting to put the application together was that almost everybody from each of those departments was already on our TBI advisory board in our state. Just by chance. We already had this working relationship. We weren't the only ones coming to the table kind of talking about brain injury. There were already people involved in the process that were kind of immersed in our brain injury world. And they also, because of that, they knew exactly who to reach out to get the brain injury representation. And I'm guessing that's not always the case in every state. So I think that that was important. I don't know if you want me to go beyond that or not. That was sort of the process.
Well, I'll just comment that I also was so grateful that it was, you know, required to have the brain injury community included. And we did have states that really wanted to collaborate with their brain injury partners, but weren't quite sure how to make that outreach. And it was so wonderful to be able to help connect those dots so that, you know, our brain injury folks are like you at the table in every state. And I would imagine too that kind of to our earlier point about what's the primary, even though they're on your brain injury advisory council, they probably are, their primary might be something else at another, you know, point in time. And so this kind of just brings it all together, which I think is really, really wonderful. So, you know, Mary, I want to maybe think a little bit about what the Link Center is evolving into. It seems like the Link Center is this real foundation for bringing, you know, the IDD, brain injury, cognitive disability communities together with behavioral health. And I think now with SAMHSA coming to the table and supporting this policy academy, do you think that, you know, is there a master plan for potentially the Link Center being this foundation for other types of subject areas where we know there's, you know, this real need for support and understanding of people with cognitive disabilities and behavioral health, where we could make some additional impacts in the future?
Well, I certainly hope so, Becky, and I think that the leadership at ACL is certainly laying that expectation as well. I think for those of you who've watched ACL over the past several years, you see them pulling pulling tables together, really setting up conversations around important issues. And the Link Center has benefited tremendously from some of those tables being pulled together around these very important issues. So we also know that in addition to brain injury and IDD and Medicaid and behavioral health coming together, we also need to think about juvenile and adult justice and child welfare and really thinking about all of the different systems that can touch someone's lives, because to really bring that holistic perspective together. So I'm especially hopeful that indeed that vision that you just laid out, Becky, can come to fruition, that we really can be a place where a convener of thinking around these particular issues, and then hopefully really amplifying those good practices so that they can take root across the country. So that's our long-term hope for the Link Center for sure.
Yeah, it really feels like it's just the tip of the iceberg right now.
Something.
Please, Eric.
It's a couple people in the chat, a couple names that popped up just talking about experiences and things of that nature. One thing I can tell you from my experience, life isn't fair, and you get in life like who you are. And I can tell you, Becky, your son, he's a winner, and he will win. He will get through this just off of just continuing to fight the good fight. A lot of times people there aren't a lot of resources out there, but I can tell you that if you bombard these ladies' email address, this is who you need to talk to, because a lot of times they don't know what they don't know. The professionals aren't always the professionals. I'm a professional person with a brain injury because I live with it. I'm a professional cancer patient. The doctor has never had cancer. He read a book on cancer. So therefore, he can't tell me how I feel. And if he decides to tell me how I feel, he will be fired and I will get another doctor. You have to take control of your own life. We have to do more to reach out to the powers that be, to flood their emails and their boxes so that they can put the money where their mouth is. A lot of times they're looking for our information, but no one wants to say anything. I've been involved in an advisory board where literally no one ever talked with a brain injury. They never said anything. So how can they be upset if nothing goes their way? So a lot of times we have to open our mouth, write it out, get a mentor, anything, a peer-to-peer situation, anything just to help us formulate our ideas so that we can help others. I know for a fact, I may not see change while I'm here, but I can guarantee you when I'm gone, some of the things that I've done will still live on. And that has to be the objective, so we can't really focus so much on what hasn't happened. Let's start today, get everyone's email address, and just hopefully it doesn't go to spam, and just flood the email addresses with whatever questions, ideas. If your state doesn't have something and you think they need it there, then we need to get it done.
Excellent point, Eric. Thank you. I did want to take just a few minutes and focus a bit more on the crisis response, because this is such an important piece of what the Link Center is focusing on. And I know it's something that a lot of states are really focusing on right now. Stephanie, would you mind kind of maybe reestablishing some, laying the foundation a bit there and talking about how challenging it is to support, people that have cognitive challenges as well as mental health concerns in this, crisis response situation?
Yeah. One thing that's really clear to me after listening to the last session actually is how much of a parallel there is between what we need to do with these coordinated crisis systems and what we've been doing for years around the no wrong door to long-term services and supports. Because when you think about it with crisis systems, you have a lot of potential touch points, right? You have crisis services that you might have crisis teams that are intervening in a particular situation in the community. You might have crisis centers that somebody's walking in on. You might have crisis call centers that someone's calling into. You might have crisis chat boxes. You've got crisis resources, web-based resources. And just like in the no wrong door system, there's a lot of places where people touch that array of services. There's a lot of reasons why they're in crisis in the first place, not the least of which might be the fact that they haven't been able to link with the appropriate resources, you know, up until now. And so I feel like the same things are true that we already know. It's important to be able to recognize that someone is living with a brain injury. And so just like I was saying earlier about this invisible injury, if you're in person, what are the signs and symptoms? What are you looking for? How do you know that this person may have experienced a brain injury in the past that might explain some of what you're seeing in the moment? But that gets really tricky when you're talking about crisis phone lines, where you can't actually see the person and you wouldn't necessarily be able to identify some of the telltale signs. And so you're listening for something, and you're also needing to, as we all know, screen, ask some questions so you can get to the bottom of that information. So this whole screening thing is going to be key. Training and helping those individuals that are working in crisis services understand that they need to be looking for this, what this might mean, how to de-escalate, how to work with someone who's living with a brain injury. And then this resource question that we, you know, have been grappling with forever, you know, linking with resources is a part of a robust crisis system. So, you know, a couple of things about that. One, there needs to be some. So you know, we need to have some brain injury services to offer up to be able to link people with. And states, we're trying like crazy to expand what we have available to people living with a brain injury. But also, it's not just one thing. I mean, people who sustain a brain injury need lots of different resources. They could be medical, they could be behavioral health, they could be some specialized brain injury program, they could be legal, it could be housing. And so, you know, I know in the no wrong door system in our state, what we've encouraged is for the warm handoff to go to the Brain Injury Association in our state, because they're the ones who know how to have the conversation. They're the ones who know how to ask the questions. And it's not just a matter of having 20 resources listed. You have to listen for so many things. Sometimes the caller doesn't even know what they're asking for yet. And so, you know, screening, training, resources, that's going to be the key. But this is just such an opportunity for us, I think, to really, for something that we've always known to be true in the brain injury world, but to be able to collaborate on a much broader level. I love that Mary is talking about communication and what, you know, I've often kind of screamed about as cognitive accessibility. In the behavioral health system, it's an expectation that you can cognitively participate at a pretty high level to be able to participate in the services. Not a lot of accommodation typically happens. So those accommodations aren't just needed when you have a brain injury, but all kinds of cognitive impairments benefit from services being able to be kind of broken down and those accommodations being made. And then there's also an issue with physical accessibility in a lot of the behavioral health services, at least in our state. So that was kind of all over the place, but those are kind of my three main points. And this is just a really exciting opportunity.
Yeah, one really, really good points. Thank you. Before we open it up to some questions from the audience, I wanted to see if either of you, if any of you had some, you know, kind of final remarks that you wanted to make sure that you mentioned today before we turn it over for some Q&A.
I would just say thank you again, Becky, to you and your team for helping shape the work of the Link Center and to really make it as inclusive as it can be. And I think we're at just the beginning. So hopefully next year we'll come back with some tales of success to share with the group.
Absolutely. I'm very much looking forward to being able to promoting the success. I did see one question in the chat so far, and you know, for people that are joining us today whose states may have been selected for the Policy Academy and they're interested in learning more, what would you suggest is the best way for them to get in touch with their states or to better understand what might be happening in their states?
It's a great question. We will be each of the states will be convening a town hall around these issues in the coming months. And so one, be on the lookout for that, but there you can also contact the Link Center if you're interested to know who in the state's taking the lead on those pieces. But there will be a public facing opportunity so that frankly, the Policy Academy faculty can get a feeling for what the partners and advocates in the state are thinking about areas of focus that would be most beneficial. So that's a real opportunity, I think, that will coming up in short order. So
that's great. And we'll have the email addresses from everyone that joined us today as well. So we can make sure that folks in those states are aware of the town halls whenever they are hosted. I am just looking. Do you mind actually, Mary, reminding us all of the states, the 6 states again that were selected?
Sure. We're thrilled to welcome Maryland, Virginia, West Virginia, Georgia, Kansas, and Ohio.
And we are hopeful there will be another round next year as well. So if your state was not, either didn't apply or maybe isn't part of it this time, hopefully they will be soon. Are there any other questions for our team? Going through the chat here. I love how active the chat is.
Becky, I'm going to jump in verbally since I have the power.
Yes.
This is Judy. What can states do? I mean, I know a lot of the policy work is focused on the 988 system and doing some training and educating and partnering with that system. If you're not a policy state, what are some strategies or thoughts that you might have about how partners can get engaged with the 988 partners in their state?
Judy, that's such a terrific question. And I certainly welcome Stephanie and Eric's thoughts on it too. Every state has a designated 988 lead. And so I think doing some outreach there, but also reaching out to your brain injury contacts and your IDD contacts to encourage the state agencies to reach out and work together. One of the things we found, we did a poll of NASD's members before we embarked on the work on the Policy Academy, and found that only about a quarter had some active engagement with their 988 Lifeline folks. And so we knew that there was work to do there. So I think sometimes it's just finding the table and getting the right folks to the table so that it, the 988 and Crisis Lifeline folks can be informed about the resources that might be available within the state.
Thank you. I know that the 988 program is front of mind for everyone because there's so much activity and communication about it, but I think sometimes we're not quite sure how to get involved and engage. So that's super helpful information. Well, I'm not seeing, I think it's by virtue of us being the last session here, I'm not seeing too many more questions in the chat. So I've been given permission to wrap up early unless we have more additional thoughts. But, I hope that this was a way that we can end your day on an inspiring and energizing note, that there is activity happening right now that will be transformational. And while we're just at the beginning stages, it is clear that we are going to be making big impacts with this work. And it takes every level. It takes the government at the federal and state level. It takes individuals with lived experience. It takes community support. It really takes all of us. And that's really, I guess, what this day is all about. Our TBI Partners Day is bringing everyone together to really promote these big transformational changes. So just again, thank you to my colleagues for joining me on this panel today. Really appreciate your time, and the discussion I think was really rich, and thank you so much.
Thank you. Please don't leave. We want to do an evaluation poll at the end, but first we'll have, actually it's up so you can do it before you leave. Sean, do you want to come on and close us off? I don't know if you put, well, your camera, if you put your camera on, they can pinpoint you. But in the meantime, please fill out the evaluation survey. Go ahead, Sean.
Oh, okay. I'm sorry. Well, first of all, on behalf of ACL, ALD, ODSI, I just want to thank everyone for participating in this wonderful, wonderful session. I'm just inspired by many of the speakers that I've heard today. It was just truly just wonderful. I'm just so excited, not only about the work that has been done, but the work that will be continued to get done. So I do want to thank many of you, many of the moderators and presenters. First of all, I want to thank Allison Burkhoff for her opening remarks. I want to thank the justice system discussion led by Zeta Ricker, Megan Davison, and Tracy Barney. Also want to thank the discussion on aging and with a TBI, Joseph Luco, Dr. Monique Papados, Martin Kerrigan, and Zuckerty. And also just want to thank our last session as well. Just wonderful, Mr. Eric Washington, Mary Sowers, Stephanie O'Day, and Rebecca Wolfgill. And also just want to, of course, I always got to thank the TARC team, Judy Detmer, Maria Crowley, also Ben Sachaki, Vivian Solomon, and of course, Terry Camacho Gonzalez for their hard work in putting this all together. So with that said, Terry, I'm going to send it back to you.
Great, thank you. Thank you so much, everyone, for joining us. This is always a highlight for us every year. Please take a moment, if you haven't yet, to respond to the evaluation questions. It really helps us to deliver high quality TBI TARC webinars. Also, if you have any questions or suggestions on how we can improve future TBI TARC webinars, such as Partners Day that we support ACL with, please send us an email. I've posted on the slide is the email address for the TBI TARC at hsri.org. And we look forward to seeing you all next year. And thank you so much. And we're almost at 80%, but keep doing those surveys if you haven't yet. We really look at that data and we utilize it to improve our webinars. Thank you and take care and have a good day.